Good morning, everybody. I am Ryan Ramsey. I am the director for the SHIP program, and this is day one of our three-day virtual volunteer training. We're going to start out with our presentation on Tennessee SHIP, the program itself, and what we do. So we'll go ahead and get started with this. SHIP. SHIP is the program that helps Medicare beneficiaries in Tennessee understand Medicare and find the best possible plans available to them right where they live. SHIP also stands for the State Health Insurance Assistance Program. There are SHIPs for every single state within the United States, though they are not all called SHIP. For example, Florida is known as SHINE. I believe California is known as HICAP. My personal favorite is Ohio. They are OSHIP, which is just could invite all sorts of fun on my part for that. That is SHIP like a boat. And for some of our beneficiaries who are a little hard of hearing, then it can be a little bit confusing for them right there. But what we provide is outreach, education, counseling, and assistance to anybody within the state of Tennessee who is in need of any sort of Medicare information or assistance. We do not solely assist with just Medicare beneficiaries. We can speak to spouses, caregivers, other family members, or representatives for a Medicare beneficiary at that point. All right, who we serve. We are serving anyone over the age of 65 who is eligible or becoming eligible for Medicare, anyone under the age of 65 and disabled who is eligible or becoming eligible for Medicare, any sort of caregivers, advocates, or family members. Anyone who essentially becomes eligible for Medicare for any reason, and anyone who is just planning for Medicare in the future. And we will go over all the different ways somebody can qualify for Medicare a little bit later on today. Reaching Tennesseans on Medicare who need our help is our top priority within the state. As I've always held the view and always stated that we are primarily a counseling program. Our primary function is speaking to and connecting to our Medicare beneficiaries across the state to help them find the plans that suit their needs the best and cost them the least. We do not partner with any sort of insurance company, nor do we even give the appearance of partnering with them. By no means do we dislike any sort of insurance company. In fact, there are many, many people who work with insurance companies who I find to be very, very smart, helpful, and knowledgeable on Medicare topics and really do assist a lot of people. But the way that I always pose it to anyone who I'm assisting is that you can feel confident knowing that I do not lose or gain any money based off of any decision anyone makes. And I am merely here to help people find and study the knowledge that it takes to make an informed decision based off of what their best choices for Medicare may be for them. There's no such thing as a best blanket statement, best Medicare plan. There is a best plan for your particular needs. Anyone who tells you that there is a best plan or they have the best plan or they sell the best plan, there's a very technical term within the insurance world, and it's called a lie, and that's what that is. There are best plans for your particular needs, not a best plan in general. Statewide, we outreach in all 95 counties throughout Tennessee with partnerships with the area agencies on aging and disability who house our SHIP coordinators statewide, other state and federal agencies, and private nonprofit organizations. We attend health fairs, conferences, group meetings, as well as give general and topic-specific Medicare presentations at churches, senior centers, state agencies, universities, libraries, etc. While I did mention earlier that we did, I should say, get shut down and we're told, hey, no outreach, no face-to-face activities of any sort within the program, we now have given the okay to begin doing face-to-face counseling, outreach activities to those who do want to, or to offer those to Medicare beneficiaries who are interested in those topics. We have asked all the coordinators to provide us with a plan of protection if somebody does intend to hold any sort of face-to-face counseling or outreach. We would ask that if you are volunteering for the program and you do intend to hold any sort of face-to-face counseling or outreach, that you do let your volunteer coordinator know that fact, as well as send them what measures you're taking in order to protect both yourself and the Medicare beneficiary if you are doing any sort of face-to-face counseling or outreach on behalf of the program. We rely heavily on past clients we've served to spread our word about the program and services we offer. For anybody who's been with the program for any amount of time, you probably have heard some variety of the statement, well, I didn't even know that y'all were here, or I didn't even know that y'all offered these services, or anything of that sort. Primarily, that's how we've gotten the word out about our program for many years, is through word of mouth. We try to maintain our good standing and our unbiased nature. It is important for us that our reputation speak for itself of being solid and providing good, unbiased, educated information about Medicare. And we rely on our past clients to recommend us to other people, as well as go out and present for ourselves about our program and what we can offer in order to get more people to contact us. We have a network of SHIP volunteers serving our beneficiaries all around the state, and we maintain partnerships with with other state and local programs and agencies to spread the word about Tennessee SHIP and how to reach us. Word of mouth is our best way to reach our 1.27 million Medicare beneficiaries in the state of Tennessee. And that does not just include interpersonal. It may be somebody sharing social media postings, us getting put in a newsletter or a radio or TV commercial, but just spreading the word that we're out there and we're available to help people is primarily how we make more people knowledgeable that we exist and are here and available to do so much in our state. We help educate Tennesseans about their Medicare. We offer presentations to the public on Medicare and Medicaid, to the public on Medicare and Medicare-specific topics, such as Medicare Parts A and B, Medicare Advantage plans, prescription drug plans, Medicare Supplemental insurance, also known as Medigap policies, how to read your Medicare summary notice, and turning 65, what is next. The way that we always present to people too is because we are unbiased and we're not allowed to give any sort of advice or recommendations. The education portion is what we lean heavily on, and what we try to tell people is we are not the people who are here to tell you what you should take or anything like that. We are the people here who are here to educate and help you empower you to make those decisions yourself. The way that I always tell people is I cannot make those decisions. I can take you up there. I can present all of your options to you, educate you on what the different choices between those options mean, but ultimately it is up to you to make your decision on what you need to go with. And we can help carry out that decision, but ultimately It is up to each person to make that decision about their health care. Counseling. We have the goal to empower seniors and disabled persons to make educated choices concerning their Medicare benefits. Our biggest job is providing one-on-one Medicare options counseling to beneficiaries, soon-to-be beneficiaries, and their families or caretakers. Typically, we advise people who are soon to be on Medicare to call anywhere from 3 to 6 months prior to their Medicare starting. If you're 3 to 5 years away from becoming Medicare eligible, it's not so important to come and get one-on-one counseling at that point, because the information that we're giving people will either be for the current year, or if it's later on in the year, it will be for the next year. But we do not have the ability to look 3 to 5 years in the future and tell anybody what the drug plans are going to look like at that point. So we do advise that about 3 to 6 months prior to being on Medicare is sort of the sweet spot for coming in and getting some Medicare counseling right there. Although it is always a good idea that if you're a couple years away from being Medicare eligible, that you please do attend one of our outreach events to sort of get some initial information and lay the groundwork to understanding Medicare, because Medicare is one of those things that many people do not come and gain a knowledge for until it's necessary. And for some people, they wait just a little bit too long, and it becomes a scramble to sort of understand and make decisions. So it is good practice to sort of start early with understanding your Medicare. We can find the best options for any Medicare beneficiary in Tennessee based on where they live in the state, the plan value, and personal preferences. Our services are always free and non-biased. We do not sell or recommend any plans. So if somebody were to come in and ask us for assistance, we would collect a small number of information from the Medicare beneficiary, go to Medicare.gov's website and enter in their information, those being things like their Medicare claim number, their zip code, their list of medications, and with what regularity and what strength for those medications. And then we would provide them with the top 2 or 3 of the plans that are the most cost effective for them when it comes to selecting a drug plan or Medicare Advantage plan. We do not charge anything for anybody coming to get one-on-one counseling, and we would not recommend any plans. The plans that we provide to people are going to be the most cost effective based off of, Medicare's website and the combination of their particular combination of medication with all the different plans and how they pay for particular medications. These are going to cover most or all of them in most situations and tell you what the lowest price is. If somebody is interested in a particular plan, we can absolutely change that comparison from just those 3 most cost-effective plans to whichever plan they're interested in. While we do put those most cost-effective plans on there, if somebody is interested in a more expensive plan, we will obviously tell them, just so you know, this plan is going to be more cost-effective. But if they do tell us, I don't care, that's the plan I want, then that's the plan that they will receive. If it is not up to us to make a decision, we inform everybody to the best of our ability of what each decision will mean. And if somebody is going to be paying more for a particular plan, we will let them know that. But ultimately, if they choose to take a plan that's more expensive or one that we necessarily privately would not think would be the most effective for them, they will receive what they want, not what we want. We also serve as a local resource for general Medicare questions, and we can assist people either face-to-face, on the telephone, or via email, whichever works best for them. Each year, we typically send out our Part D or prescription drug plan worksheet that we do create each fall in preparation for the annual enrollment period. We do always send those out throughout the year as well to anyone who is looking to get a comparison. However, we can take that information over the phone or they can provide it via email as well, but it's entirely up to them. But we have very much the capability to handle counseling through all those three ways, especially since one of those has been unavailable for the past year or so. We very much did not miss a step in terms of being able to still assist people in those scenarios. For assistance, we also screen and provide enrollment assistance for the following low-income programs, that being the extra help with Part D prescriptions, the low-income subsidy, as you might see it, LIS, that is through the Social Security Administration, and Medicare savings programs through TennCare. You may see those as the Qualified Medicare Beneficiary Program, QMB. That's Q, M as in Mary, and B as in boy. The specific low-income Medicare beneficiary, that's SLMB, S as in Sam, L, M as in Mary, B as in boy, and QI1, Qualifying Individual 1 program through TennCare right there. But we always screen people to see if they would qualify for that, and if they wish to put in an application, regardless of whether they meet those income limits or not, if somebody still wants to put in an application regardless, or if they are under those, we will help people fill out and submit those applications as best we can. The impact of SHIP counseling and education. Unfortunately, SHIP is not permitted to share this information right now due to some quality assurance work that ACL and SHIP have been doing to sort of make sure that all of their cost outcomes work. Cost outcomes would be when we do a comparison and enroll somebody into a plan in any given year. When we enter that into our database, we put what the cost of their previous drug plan, or if they are new to Medicare, what the full cost of those medications would be compared to what the new cost of their new plan, or if they did not have a plan, now that they do have a drug plan, what the cost of those medications are going to be through the remainder of the year. And it gives us a cost outcome, whether that is we save them money or they're going to be still paying more than they would have been in the year previous or prior to this enrollment. We do keep that on record. ACL has the project right now of going in and any sort of issue, or, you know, if there was for example, an alphabetical value put in there rather than simply numbers and a decimal point, and there would be some sort of outlier for what would be flagged in the system. They're asking everybody to go through for the next few months and correct any of those mistakes. And until that happens, ACL has not permitted SHIPs to share any of the information for contacts reached or for money saved or cost outcomes, I should say, not necessarily savings, although I would say in an overwhelming majority of cases when it comes to enrollments with the SHIP program, we have saved people money as opposed to them getting onto a plan that's going to cost them more. But at this time, we cannot share that information. Just as soon as we can, we'll make sure and add that to a presentation and make sure that that is recorded because we would like to make sure that all the work that the SHIP coordinators and the volunteers is presented in as soon as possible. The volunteer impact for the past year. We have maintained 431 volunteers and staff statewide with the SHIP program, which combined all have totaled 46,647 hours of service for the SHIP program, which is very impressive. Contact your local Tennessee SHIP program. This number right here, the toll-free number, that's 1-877-801-0044. That will take everybody to the SHIP hotline and will route everyone to our SHIP call center. Our SHIP call center located here in Nashville. The agents take each beneficiary's information. They ask them, questions to figure out why they're calling the program, take the information that is necessary in order to help route them to the correct AAAD, which serves in that particular region of the state, and they will route those calls to the coordinators in that region to make sure that everyone is receiving localized assistance when it comes to the questions that they have, and the coordinators receive those calls the following day and are able to call back to the beneficiary and offer them any assistance possible. Any clients or the general public is free to call this number. There's a chance that you will see this number. In many places we do try to advertise it to everybody, and we do always have people who are not looking for any sort of specific Medicare information. They are rather looking for information of another sort. Even if somebody calls into our hotline, our agents do try to give them the correct number to where they're going, or let them know that it is an entirely different program from what they're calling and asking them about, and we'll send them to our information and assistance line to help them better find the services that they're looking for. All right, and that is the end of that presentation. Does anybody have any questions that they would like to ask, or anything that is not clear regarding the program? I didn't see any questions, but I'll give a few seconds for anybody to ask any questions here. Okay, all right.
Understanding that. So what is Medicare? Medicare is health insurance for three groups of people: those that are 65 and older, those that are under 65 with certain disabilities such as ALS, known as Lou Gehrig's disease, and that is without a waiting period, and any age with end-stage renal disease. It is administered by the Center for Medicare and Medicaid Services, and you do enroll through either Social Security Administration or the Railroad Retirement Board. Now, in order to get Medicare, you must be either a U.S. citizen or lawfully present in the U.S. Now, there are four parts of Medicare. There's Original Medicare, which is Part A, which is your hospital insurance, Part B, which is your medical insurance. There is also Medicare Advantage, which is also called Part C, and that includes the Part A hospital, Part B medical, and usually a Part D drug plan. And then there is Part D, which is the Medicare prescription drug coverage. Now, there are two options when you're looking at how you're going to have your Medicare. Option one is Original Medicare, and this includes Part A hospital insurance and Part B medical insurance. You would then add a Part D Medicare prescription drug coverage, and you can also add a Medigap policy. This is also known as a Medicare supplement insurance. So you may hear it as both Medigap and Medicare supplement. The second option is the Medicare Advantage plan. Now, these plans are usually like HMOs or PPOs, and they typically do include a Part D prescription drug plan. So it will have incorporated into the Medicare Advantage plan the Part A hospital, Part B medical, and Part D prescription drug plan. Now, one important note is you cannot have a Medicare Advantage and a separate original Medicare with a prescription drug and a Medicare supplement. Your option is one or the other. And you can find this on page 6 of the Medicare and You Handbook. Now, automatic enrollment with Part A and Part B. You will be automatically enrolled if you are receiving either Social Security benefits or Railroad Retirement Board benefits. You will get an initial enrollment period package that is typically mailed 3 months before you turn 65 or on the 25th month of disability benefits. So you are eligible for Medicare when you have received disability for 24 months. You get your Medicare on the 25th month and you are automatically enrolled. It includes your Medicare card. Now, others that are not receiving Social Security benefits or Railroad Retirement Board benefits must enroll themselves. Now, you must take action to enroll in Medicare when it is not automatic. If you're not automatically enrolled in Part A and Part B, so you're not getting Social Security or Railroad Retirement benefits, you need to enroll with Social Security. You can visit socialsecurity.gov and do your enrollment there. You can also call 1-800-772-1213. That is Social Security's number. Since we are still feeling the effects of COVID, typically you can make an appointment to visit your local office. However, right now, that really is not happening. So they have drop boxes where you can do a paper enrollment and drop that off. You can apply 3 months before you turn age 65. If you've retired from a railroad, then you enroll through the Railroad Retirement Board. And you can also call the Railroad Retirement Board office at 877-772-5772. Now, there is a 7-month initial enrollment period. That is 3 months before you turn 65, the month you turn 65, and 3 months after you turn 65. If you enroll in your Medicare Part A and B, then your coverage begins the first of the month when you turn 65. If you wait until the months after you turn 65, those 3 months, your Medicare could be delayed 2 to 3 months. And for Part A, if you have to buy it, and or Part B. So during your initial enrollment period, you can enroll or join A and B and not have any late enrollment penalties. Now we're going to go into Medicare Part A, which is hospital insurance. So paying for Part A, most people don't pay a premium for Part A. If you have paid Federal Insurance Contribution Act, FICA taxes for at least 10 years, or if you're married, if your spouse has paid those FICA taxes for 10 years. If you paid FICA taxes less than 10 years, you can pay a premium to get Part A. Now, you may have to pay a penalty if you don't enroll when you're first eligible for Premium Part A. That is the Part A where you're going to have to pay a premium towards that. Your monthly premium may go up by 10%, and you may have to pay the higher premium for twice the number of years you could have had that Premium Part A, but you didn't sign up. So for 2021, These are the Part A premiums. As you see, for 40 or more quarters, there is a zero premium that you pay. If you have 30 to 39 quarters, it's going to be $259 a month. If you have 29 quarters or less quarters, then it will be $471 a month. Now, Medicare Part A covers the following services. You have your inpatient hospital stays, which is your semi-private room, your meals, general nursing, and other hospital services and supplies. It includes care in critical access hospitals and inpatient rehabilitation facilities. Now, an important note, for inpatient mental health care in psychiatric hospitals, you have a lifetime limit of 190 days. Generally, it covers all the drugs provided during an inpatient stay received as part of your treatment. Also, skilled nursing facility care. That's your semi-private room, your meals, your skilled nursing, and your rehabilitation services and other services and supplies. Home health care services. It can include part or intermediate skilled care and physical therapy, speech language pathology, a continuing need for occupational therapy, some home health aid services, medical social services, and medical supplies. Part A includes hospice care. This is for the terminally ill and includes the drugs, medical care, and support services for a Medicare-approved hospice. And then blood. In most cases, if you need blood as an inpatient, you won't have to pay for it or replace it. Now, there are benefit periods in original Medicare when you are looking at Part A, and the measures use of inpatient hospital and skilled nursing facility. So it begins the day you first get inpatient care in the hospital or skilled nursing facility, and the benefit period ends when you are not in the hospital or skilled nursing facility 60 days in a row. So you pay a Part A deductible for each benefit period. For 2021, that Part A deductible is $1,484. There is no limit to the number of benefit periods you can have, and the benefit periods can span across calendar years. Now, Mrs. Smith enters the hospital on January 1st, 2021. She's treated and released January 15th, 2021. Ms. Smith returns to the hospital on February 20th, 2021. So is she still within her benefit period? Yes, she is, because she returned to the hospital in less than 60 days. And so how many times will she have to pay her Part A deductible? Only the once, because this all happened within a 60-day period. Now, Mr. Andrews enters the hospital on June 30th, 2021. He's treated and is released on July 31st, 2021. Mr. Andrews returns to the hospital on November 15th, 2021. Is he still within his benefit period? No, he is not. He has been out of the hospital more than 60 days. So how many times will he have to pay his Part A deductible? It will be twice, because he was out of the hospital for longer than 60 days in a row. Now, paying for the inpatient hospital stays. For days 1 through 60, you will pay $1,484 deductible. For days 61 through 90, it's $371 per day. And for days 91 through 150, it's $742 per day. These last 60 days are lifetime reserve days. As you use these days within your lifetime being on Medicare, they do not reset, they do not refill. Once you use them, they are gone. After the 150 days, all the costs are on you for the inpatient hospital stay. Now, skilled nursing facility care. There are some important things to be aware of when you're looking to go into a skilled nursing facility. You must meet all the conditions. You require daily skilled services, not just long-term or custodial care. You must have a hospital inpatient. You can't be there for just being looked at. You have to be inpatient. You can't be there for where they have you there and they're watching you. And it must be for 3 consecutive nights or longer. So these must be midnight, overnight stays. And the day that they discharge you does not count. You have to be admitted to the skilled nursing facility within a specific time frame. So generally, it's 30 days after leaving the hospital. The skilled nursing facility care must be a hospital-treated condition or a condition that arose while receiving care in a skilled nursing facility for a hospital-treated condition. And again, and you will see this a lot, it must be a Medicare participating skilled nursing facility. Now, the cost for paying for skilled nursing facility care. For days 1 through 20, there is no copay. For days 21 through 100, it's $185.50 per day. After those 100 days, all the costs are on you for that skilled nursing facility. Now, for health care, there are 5 conditions for home health care. You must be homebound, and there is a new definition of homebound that has clarified to more accurately reflect the definition in Section 1835A of the Social Security Act. You must need skilled care on a part-time or intermittent basis. You must be under the care of a doctor. You must be receiving services under a plan of care. You must have a face-to-face encounter with the doctor, and that face-to-face must be prior to the start of care. And again, the home health agency must be Medicare approved. Now, paying for home health care, you're fully covered by Medicare. There is a plan of care reviewed every 60 days. This is called the episode of care. If you are in original Medicare, not a Medicare Advantage plan, but original Medicare, you pay nothing for the covered home health care services and 20% of the Medicare approved amount. For the durable medical equipment, so the durable medical equipment is covered by Part B, as in boy. Hospice care. This is special care for the terminally ill and their family if you are expected to live 6 months or less. It focuses on comfort and pain relief, not a cure. The doctor must certify each benefit period. So the first 2 are 90-day periods, and then you have unlimited 60-day periods. And it does require, with the doctor, a face-to-face encounter. And again, the hospice provider must be Medicare approved. Now, the covered hospice services. It covers the physician and nursing services, the medical equipment and supplies, your drugs for symptom control and pain relief, short-term hospital inpatient care. It also covers respite care in a Medicare certified facility for up to 5 days each time with no limit to the times. It will include a hospice aide and homemaker services, social worker services, grief, dietary, and other counseling, also physical, occupational, and speech therapy. Now, paying for hospice care. If you are in original Medicare, you pay nothing for hospice care and up to $5 per prescription to manage pain and symptoms while you're at home. And it is 5% for inpatient respite care. That is your portion. Room and board may be covered if the short-term respite care is for pain symptom management. Also, if you have Medicaid and live in a nursing facility. Now, blood when you're inpatient, because we're still talking about Medicare Part A. If the hospital gets blood free from the blood bank, you won't have to pay for it or replace it. If the hospital has to buy blood for you, you pay for the first 3 units per calendar year. Or you or someone else can donate to replace the blood, and then you would not have to pay for it, to pay for the first 3 units. Now we're going to go on to Medicare Part B. That's B as in medical insurance. Now, it's the same 7-month initial enrollment period, which again is 3 months before you turn 65, the month you turn 65, or 3 months following when you turn 65. This is, your coverage will begin the first of the month that you turn 65, or if you delay it for the 3 months after you turn 65, the start of your Medicare could be delayed 2 to 3 months. And during your initial enrollment period, you can enroll and join in Medicare Part A and Part B. And again, there are no late enrollment penalties. There is a general enrollment period. Now, a general enrollment period for Part B is January 1st through March 31st each year. If you did not enroll in Medicare Part B when you were first eligible, this is the time that Medicare gives you to be able to enroll. And your coverage starts July 1st. So you can, through the general enrollment period, enroll in Part B between January 1st to March 31st. From April 1st to June 30th, you can pick a plan, and then your Part B coverage will start July 1st. Now, the premium penalty is 10% for each 12-month period that you were eligible but not enrolled. And you must pay that penalty as long as you have Part B. There are limited exceptions to that. Now, with the Part B late enrollment penalty, you want to see how your insurance works with Medicare. So always check with your employer or your union benefits employer to make sure if you're going to stay on that plan that it is considered credible coverage. You don't want to take a misstep and wind up with the penalty. And the penalty for not signing up again when you are first eligible is 10%. For each full 12-month period. And again, you may have to pay a penalty as long as you have Part B. So you sign up during a special enrollment period, and usually there is no penalty if you sign up within 8 months of your employer coverage ending. So this is the employer group coverage. Now, the Part D late enrollment penalty, here is an example. Mary delayed signing up for Part B 2 full years after she was eligible. She will pay a 10% penalty for each full 12-month period she delayed. The penalty is added to the Part B monthly premium, which for 2021 is $148.50. So for 2021, her premium would be as follows. She would have her standard 2021 Part B premium, which would be $148.50, and then her penalty would be $29.70. That's 20% of the $148.50. So her premium for 2021 would be $178.20 because we're adding the $148.50, which is the standard, the $29.70, which is the penalty. Now, the monthly Part B premium That is looked at by your tax return for 2 years previous. So for 2021, we are looking at the 2019 tax return. If your individual return was 88,000 or less, or if your joint return was 176,000 or less, then you would pay in 2021 $148.50. If it was 88,000 to 111,000 for an individual, or 176,001,000 to 222,000 filing jointly, it would be 207.90. So sorry, 207.90. 111,001 to 138,000 individual, and 222,001 cent to 267,000 would be $297. 138,001 cent to 165,000 for individual, and for a joint return, 267,001 cent to 330,000 would be $386.10. For 163,001 penny to 499,999 would be for an individual, and for a joint return, 330,001 cent to 749,999 would be 475.20. For an individual, 500,000 and above, and for a joint, 750,000 and above would be 504,090. So the more that your tax return for 2 years previous, the higher that is, the more you're going to pay. Social Security does allow you to file an appeal if in 2 years previous your income was higher than it will be for the current year. Now, the Part B premium paying for this, it is deducted monthly from your Social Security payments, your railroad retirement payments, or your federal retirement payments. And if it is not deducted, you are billed every 3 months. And Medicare will send that bill out, and there is a Medicare Easy Pay to deduct from your bank account. You can mail it in with a check. You can set up with your bank to make the payment. You can pay by credit card. There are all different options to be able to pay this. And you can contact Social Security Administration, Railroad Retirement Board, or the Office of Personnel Management. That last is for the federal retirement benefits about premiums. Now, paying for the Part B services. If you are an original Medicare, then you will pay a yearly deductible. For 2021, that's $203. After that, you would pay 20% coinsurance for most services. And there are some programs that may help with these costs. Now, Part B and employer or union coverage. It may affect your Part B enrollment rights. So you may want to delay enrolling in Part B if you have employer or union coverage, and if you or your spouse or family member, if you are disabled and if you or your spouse or family member, if you are disabled, is still working. You need to see how your insurance works with Medicare. You do need to contact the employer or union benefits administrator. When employer or union coverage ends, when your employment coverage ends, you may get a chance to enroll in COBRA for 18 months. You may get a special enrollment period 8 months after your employer coverage ends to enroll in the Part B, and that would be without a penalty. Now, Medicare and TRICARE coverage. And TRICARE is for those that have been in the military and have retired from the military. And that would be Medicare Part A and TRICARE for life. If you're retired, you must have Part B to keep TRICARE. If you're an active duty member, spouse, or dependent child, you don't have to have Part B to keep TRICARE. And you get a Part B special enrollment period if you have Medicare because you are age 65 or because you are disabled. Now, Medicare Part D coverage. This is what it covers. The first is doctor services, and these are services that are medically necessary, including outpatient and some doctor services you get when you're a hospital inpatient or covered preventative services. Except for certain preventative services, you pay 20% of the Medicare approved amount if the doctor accepts assignment and the Part B deductible applies. Also, outpatient medical and surgical services supplies. So it's for approved procedures like x-rays, a cast, stitches. Again, you pay the doctor 20% of the Medicare approved amount for the doctor's services if the doctor accepts assignment. You also pay the hospital a copayment for each service, and the Part B deductible does apply, which again for this year is $203. Home health care services. Some of the things are covered under Part B, which medically necessary part-time or intermediate skilled nursing care, physical therapy, speech language pathology services, occupational therapy, part-time or intermediate home health aid services, medical social services and medical supplies, durable medical equipment, and an osteoporosis drug are also covered under Part B. So durable medical equipment would be, for example, a hospital bed, as well as crutches or a wheelchair. Those are considered durable. Those are just some examples of durable medical equipment. An osteoporosis drug would be one that would have to be administered in a doctor's office or an outpatient setting. So it have to be done by a doctor or someone under medical, and you pay nothing for covered services. And this goes in a little bit more for the durable medical equipment, as I said, such as oxygen and their supplies, wheelchairs, walkers, hospital beds for use in the home, and some items such as the hospital beds must be rented. You pay 20% of the Medicare approved amount and the Part B deductible applies. And then there are others these are included but not limited to medically necessary medical services and supplies such as clinical laboratory services, diabetic supplies, kidney dialysis services and supplies, mental health care, limited outpatient prescription drugs, diagnostic x-rays, MRIs, CT scans, EKGs, transplants, and other services are covered, and the costs may vary. Now, this is a list of the Medicare Part D covered preventative services. And with these services, the one that I did want to point out is the Welcome to Medicare preventative visit. When you have original Medicare, within the first 12 months of having Medicare, you are entitled to a Welcome to Medicare preventative visit. After that, you would get a yearly wellness visit. The doctor must code this as a Welcome to Medicare. Otherwise, Medicare will not pay for it in the first year. But there is a very long list, and you can read it here, of what is covered for preventative services. Now, what is not covered by Medicare A and B? Long-term care, routine dental care, dentures, cosmetic surgery, acupuncture, hearing aids and exams for fitting hearing aids, and there are others. So you always want to check on Medicare.gov. You can type in the search bar what you're looking to see how it's covered, and Medicare.gov will actually bring it up and you can see how it's covered and how it's billed. Now, there is an advanced beneficiary notice of non-coverage, known as an ABN. You will get this notice if you have original Medicare and your provider thinks that Medicare probably or certainly won't pay for the items or services. So the advanced beneficiary notice of non-coverage will list the items or services that Medicare isn't expected to pay for, an estimate of the cost for the items and services, and the reasons why Medicare may not pay for that particular service or item. Okay, and that's the end of my presentation. So there are some questions.
Marianne, it was asked, is there a difference in terminology when you delay Part B coverage due to an employee health benefit and outright refusing Part B coverage?
There is not a difference in terminology that I am aware of. Either you are accepting Part B or you are refusing it. And when you
I would
go ahead.
I would say the only difference would be that if you're delaying it due to Part B, or if you're delaying it due to having coverage under your employer's health benefit, then that would be creditable coverage that would not lead to you gaining a penalty, but outright just refusing it, and you don't have an employer health benefit, then you would obviously be incurring a penalty from that point.
Right. That's where I was going. So you took the words right out of my mouth.
Sorry.
And as Adrian put in here, this is definitely good. You want to check your Medicare summary notice. That's what MSN stands for, to make sure that the doctor has coded that welcome to Medicare service correctly. Because what will happen is you'll have to go back to the doctor, they'll have to recode it and then have to resubmit it. So forewarned, as I always say, is forearmed. Are there any other questions?
Let's see here. Is VA insurance still considered creditable coverage? To which Tyler had responded, only for Part D coverage, unless that being TRICARE or CHAMP VA.
Correct, because if you have VA and you do not take your Part B and you only take Part A because there's no premium for it, number one, you won't be able to go anywhere but the VA, otherwise you'll pay it out of pocket. And when you do go to get that Part B, you will incur a penalty. It does not, having VA coverage does not stop you from getting that Part B penalty.
Any other questions for Marianne?
Well, thank you, everyone.
All righty. We'll get this show on the road and explore the exciting world of Medigap policy. So when you hear Medigap, you can hear it in two different ways. You'll hear Medigap, and you'll also hear Medicare supplementary insurance. If you hear those two terms, it just means the exact same thing. What Medigap is it's private health insurance, so it's provided by private insurance companies. So it's like us purchasing a private policy from another company to cover what Medicare doesn't. It's not completely attached to Medicare, it's us purchasing a separate policy. It supplements original Medicare and it helps pay what Medicare doesn't. As we learned from Mary Ann, Medicare Part A and Part B pays 80% naturally, so the Medigap policy that we purchase is there to cover that 20% that Medicare doesn't. It will pay its share as long as Medicare pays. So that's kind of the kicker when it comes to supplemental insurance, is as long as Medicare pays, the supplemental plan pays. If Medicare doesn't pay, then the supplemental plan is not going to pay either because it's only designed to cover what's left. A Medigap policy is only going to cover one person, so it's one policy per person. So if you have a couple on Medicare, one Medigap policy is not going to cover the both of them. Both individuals are going to have to carry a Medigap policy on their own to be covered. So original Medicare doesn't cover everything. It only covers that 80%. What we pay is we pay our share of deductibles, co-insurance, what's left on the bill, co-payments, if we have any co-payments with our plans, monthly premiums, so that $148.50 Medicare Part B monthly premium, and then any additional premiums that we have with our Medigap supplemental policy and our Part D. Medigap policies will typically pay all or part of your share. There are going to be different plan types that cover different things. You will have plan types that will mostly cover everything that Medicare doesn't, and then you'll have some kind of modified policies that will cover part of what's left. The coverage is just going to depend on the plan type that you purchase. So the best time to purchase a Medigap policy is going to be within your Medigap open enrollment period. You're also going to hear this called your guaranteed issue period. Now this period always starts 6 months, or it's going to last up to 6 months after your Medicare Part B goes into effect. So once your Medicare Part B goes into effect, you're going to have a 6-month period afterward to purchase a supplemental policy and be guaranteed a policy without being subject to something called medical underwriting, which is basically just a fancy way of saying that they're going to punch you through a bunch of medical questioning to try to root out pre-existing conditions and to see whether or not they're going to carry you on coverage. During the 6-month period of your Medigap open enrollment period or the guaranteed issue period, they can't ask you any of those questions. They can't know anything about your medical history, and they are required to offer you coverage, so they cannot deny you in any way. Your OAP, or your open enrollment period, begins when you're 65 or older and enroll in Part B. Now, it can't be changed or repeated. So once we've went through this guaranteed issue period, we can't get it back. It may be able to, or you may be able to buy a Medigap policy anytime an insurance company will sell you one. So this guaranteed issue period doesn't mean this is the only time that we can purchase a supplemental policy. We could purchase a supplemental policy anytime during the year because there's not a set enrollment period of when we have to purchase a Medigap policy. Any of these companies that are selling Medigap policies can sell us one anytime throughout the year, but when we're without, or when we're outside of our Medigap open enrollment or a guaranteed issue period, that's when we will be subject to medical questioning. So it'll all depend from there whether or not the company is going to cover us based on the questions that we answer. If you delay enrolling in Medicare Part B, let's say due to ourself or a spouse still working and carrying a group health coverage plan through our employer benefits, we will still get that guaranteed issue period upon ending those employer health benefits. So we still get that, and it will be tied to our Medicare Part B start. Medigap open enrollment period is delayed until we are 65 or enrolled in Part B. So the moment that we enroll in Part B, that's when that guaranteed issue period starts ticking. There is no late enrollment period for Medigap, so we can purchase that at any time. And we must notify Social Security if we do wish to delay Part B. So going back on what Mary Ann said earlier, if we are refusing Part B, then that's something that upon enrolling into Medicare is something that we have to notify Social Security and manually do. It's something that they're not going to do automatically. So pre-existing conditions in Medigap. Health problems that you've had before the new insurance policy starts, that's just defined as treated or diagnosed 6 months before coverage start date. Where pre-existing conditions really come into play is if we're outside of that open enrollment period for Medigap or outside of our guaranteed issue period. Now, as long as we're in that guaranteed issue period, they can't know anything about our pre-existing conditions. But if we are outside of that period, that's where they can put us through that medical underwriting. And it's where those pre-existing conditions can possibly come into play when it comes to delaying our coverage or being straight up denied for coverage. There is something that Medigap policy or Medigap companies can do called pre-existing condition waiting periods. It's insurance companies can use to cover out-of-pocket costs for an excluded condition for up to 6 months. They call that a look-back period. So if they can say that, oh, well, we see that you have this pre-existing condition, we don't normally cover this condition, but if you will go through a 6-month look-back period where we don't cover you for any treatment considering this condition, after that 6 months, we will pick you up in coverage for that condition. So without 6 months of prior creditable coverage, there might be a break in coverage if we don't have anything more than that 63 days of the plan ending. So if we're put through that look-back period, we want to make sure there's going to be something in between there that's going to help cover us if we do have to wait that 6-month look back period for a pre-existing condition. So it says at the bottom there, the Affordable Care Act doesn't impact the pre-existing condition waiting period for Medigap coverage. It doesn't impact anything on what they can look at and limit for us when it comes to pre-existing conditions. Mainly what the Affordable Care Act does is they're the ones who put that guaranteed issue period in the place where they can't ask us questions for up to that 6 months. So standardized plans, they are lettered out by Medicare, so it can get a little confusing because Medicare letters everything out as well. So we have to think of Supplemental Medigap as separate from Medicare when it comes to these plans and letters, because if we try to think of them together, we're going to be mixing all sorts of things up and it gets really confusing. So we want to make sure we kind of think of Medigap as its own thing. They have their plan types lettered out as well. We're going to have plans A, B, C, D, F, G, K, L, M, and N that you're going to see currently on the market. Now, we're going to see a lot of restrictions for Plan C and F, and we'll talk about that very shortly. Those are not currently on the market for new customers coming into Medicare, and I'll explain a little bit about that here in just a minute. companies don't have to sell all plans. So just because they are licensed to sell Medigap doesn't mean that they have to offer all of the different plan types. They can pick and choose which plan types they're going to decide to sell. So they can decide to sell all 8 currently on the market, or they can decide to sell only 1 or 2, or mix and match depending on what they feel like they're going to have the biggest market for. Plans E, H, and I, and J exist but are no longer sold. And this is true with CNF too. CNF are no longer sold on the market to new customers, along with E, H, I, and J, even though you will still see beneficiaries with these plan types. And the reason why these plan types are no longer on the market is because Medicare, even though these policies are sold by private insurance companies, Medicare is the ones that mandates them and makes all the rules. And they've taken away certain coverages that these old plans provided. And so they are obsolete on the market. They're no longer to be able to be sold, but people who are still on these plans were able to grandfather in. So it's not something where you have to switch to another plan. You are able to grandfather in. So if you're already on the plan, you can keep holding it. So that's why you will still see these plans in existence, even though they're no longer sold on the current market. Plans with the same letter must offer the same benefits. So if companies offer, let's say, a plan G, it doesn't matter what company offers it, plan G has to have that amount of designated coverage no matter what company you go through. So all these different plan types are going to have a set coverage. So if company A or company 1 sells plan G and company 2 sells a plan G, they both have to have the same coverage. It has to be plan G coverage. It can't be modified in any way. So that's kind of the standard when we look at Medigap. Is it's all about what plan type we're looking to purchase, because we know what coverage it's going to have. It can't change. The only thing that really changes is going to be the cost. So these different companies are going to offer different prices for the same plan, but the coverage is going to stay the same. And then you have your waiver states, with the exception of Massachusetts, Minnesota, and Wisconsin, that standardize their plans in a different way. With us being in Tennessee, we're not one of those waiver states, so we go by the basic Medicare mandates. So these are the different Medigap plan types. You will see them lettered out there. You have A, B, C, D, F, G, K, L, M, and N charted out. And you'll see that on the left-hand side, we'll see that this chart kind of goes over the amount of coverage that each plan has. Some of the categories that these Medigap plan types can cover is our Part A coinsurance and hospital costs. So that's anything from our inpatient hospital stays or skilled nursing that's left over from Medicare Part A. And then we have our Medicare Part B coinsurance or copayment. So this is anything left over from our outpatient expenses, anything that you can think of, doctors, specialists, x-rays, tests, outpatient procedures, observation. So anything that you can think of that would be outpatient falls under Part B coinsurance. And then we have category where it can cover our blood. If we're in a hospital and we need a blood transfusion, they can cover what's left on the payment for the pints of blood up to the first 3 pints. Our next one is Part A, hospice coinsurance or copayment. So for hospice care, we can have coverage for what's left of hospice care after Medicare pays. Any of our skilled nursing facility care insurance, so that's all kind of fall under Part A as well. You will also see coverages for our deductibles as well. We have the Part A deductible, and you see that several or most of our plans there will have coverage for the Part A deductible. It looks like only Plan A is the main one that doesn't have any coverage for it as well, or for it at all. And then K and L will have modified coverage for the Part A deductible. And then we have the Part B deductible. This is the main reason why Plan C and Plan F are no longer in the current market, is because 2 years ago, Medicare changed the policy to where they kind of eliminated the Medigap plan being able to cover that Part B deductible. So you will still see CNF in existence, though, with excuse me, with beneficiaries still holding those plans because they grandfathered into them. So if you see a Plan C or Plan F out there, you will know that those two plans also covered the Part B deductible. They are the only two current plans that do that. No other plan covers the Part B deductible. But that's why these plans are no longer on the market to new customers, because Medicare had changed the coverage for them being able to do that. Now, next we have the Part B excess charges. The best way I know how to explain a Part B excess charge is with an example. Let's say that we go to a doctor who is not currently accepting the Medicare assignment, which just means that they're not currently accepting Medicare approved amounts. They haven't signed that contract with Medicare to accept those negotiated prices, but they decide to see us as a patient anyway and bill Medicare for it. In that instance, that provider can bill up to 15% more than that Medicare approved amount or that Medicare negotiated price. In that instance, anything more that was billed past that Medicare approved amount would be considered an excess charge. And it looks like on this chart, if we have anything other than a Plan F or a Plan G, then we would be responsible for that excess charge. But on the flip side of that, if we're going and seeing a doctor who does take the Medicare assignment, they have signed that contract to take the Medicare negotiated prices, then they can't bill anything more than that Medicare approved amount. So those excess charges don't come into play. So those Part B excess charges are really only concerning to us if we're seeing providers outside of that Medicare assignment. Now, you will see on the next one, you'll see coverage for foreign travel emergency. This is going to be for anyone going outside of the country. It'll be kind of like an emergency policy. It's only going to cover emergency care, and it's going to be up to 80%. And now plans are going to have certain limits on those. And typically it's only 80% for emergency. So it's one of those ordeals where it does have some kind of form of travel insurance there, but at the same time, it doesn't replace traveler's insurance. This is only going to cover up to 80% for emergency care. So if we needed any kind of routine coverage or long-term coverage if something catastrophic happened while we were outside of the country, we would still want to have some form of traveler's insurance or something to supplement that as a primary. So it's not something that we advise people to lean on, but it is a really cool thing that if you are outside the country and needed some kind of emergency care, this is kind of a good safety net to fall back on. Now, there are two plans that have out-of-pocket limits when it comes to the Medigap policies. That is Plan K and Plan L. The reason why these two plans have out-of-pocket maximums or out-of-pocket limits is because they're not full coverage when it comes to covering what's left of Medicare. As you see with Plan K, on a lot of the categories there, like the Part B, the blood, the Part A coinsurance, skilled nursing, and Part A deductible, it's only going to cover 15% of those, or 50% of those, sorry. 50% of those that are left off from Medicare. So if you think about that in the way of these plans cover the 20% that Medicare doesn't cover, with K covering 50% of those, you can kind of equate to that for it covering the 10% that's left off of Medicare. So it's going to cover me for that 10%. So Medicare is going to cover 80, Plan K is going to cover 10, and then we're going to be left with the remaining 10. And then that's the exact same way with Plan L, with it covering 75% of those categories. We can equate that to 15% coverage. So Medicare Part A and Part B covers our 80, Plan L covers our 15, and then we're left with the remaining 5. And you're right, they are cheaper because of that. They're going to have lower premiums than your other plan types that are going to have more coverages, but at the same time you're going to have out of pocket. So it's going to kind of depend on what your situation is as a patient, whether or not those plans are going to be the most cost effective for you. Because obviously if we have a lot of medical expenses, those may not be the plans that we choose because we would have a lot out of pocket. But it's all about what's going to fit us as a patient, and that's definitely a option when it comes to Medigap policies if we don't need that full 20% coverage. So we do have some policy changes in the last little bit when it comes to Medigap supplemental policy. There are limitations on certain Medigap policies for people newly eligible to Medicare. Like I was explaining earlier, that's where those C and F plans are no longer sold on the market. As of January 1st of 2020, Medigap policies sold to people newly eligible for Medicare will no longer provide coverage for the Part B deductible. So that for this year, the Part B deductible is $203. So for new customers coming into Medicare purchasing Medigap policies, they can no longer purchase C and F that previously did cover that deductible. Newly eligible means an individual who before January 1st, 2020 is neither 65 nor has Part A. So this does not include anybody that had Medicare before January 1st of 2020. If a beneficiary did have Medicare before that deadline, basically, they can still purchase a Plan C and F if those companies are willing to sell them a policy Plan C or F. It's just those who are coming into Medicare brand new after January 1st, 2020, those are the ones that are no longer able to purchase those policies. But anybody who is currently on a Plan C or F does not have to leave that plan. They will be grandfathered into that plan and be able to retain it at whatever policy rate that their company has them on, and subject to that company's rate change. Any policies bought before January 1st, 2020 won't be affected. They grandfather in. So one Medigap supplemental policy plan that will be available to certain people that we counsel is the UMR POMCO plan, or you'll also hear referred to as the Tennessee plan. Those who are eligible for this plan are those who worked for the state of Tennessee. The state of Tennessee retirees can be eligible for this plan, and it is equal to a Plan D on the market. So if we go back to that chart, it will line up exactly with what Plan D as in dog covers. Now, for those who are eligible for the POMCO plan, I believe you have to have at least 10 years of service to be eligible for the POMCO plan. So you have to have 10 years of service with the state of Tennessee. And we do get discounts based on our years of service with the state. So below there, you will see a chart that explains the discounts that we get. So if we have less than 15 years of service, then our standard rate with POMCO would be $140.55 per month. And then if we have 15 and 19 years of service, then our rate gets discounted to $115.55 a month. And then if we have 20 to 29 years of service, it goes down to $103.05 a month. And then we have our greatest benefit, which is that 30 plus years. If we have someone who has been a teacher or a direct state employee for over 30 years, they're going to get that highest benefit, which is knocked down to $90.55. So when you're counseling someone who is eligible for POMCO, obviously they've been a state employee, or the most common you'll see as well is teachers, because of that state benefits administration, the state teachers retirement plan. They are eligible for that POMCO plan as well. And so this is the chart we're going to use to kind of determine what their years of service are and what their benefit is going to look like if they decide to take this plan. Now, if they do decide to enroll in the POMCO plan for their Medigap supplemental, the way that they would do this is they would apply through the state benefits administration. So there is a high deductible option when it comes to Medigap. Previously, it was attached to Plan F. The deductible amount for 2021 is $2,370. And because Plan F is no longer sold to new customers, I believe you can get a high deductible option of the step down from Plan F, which is Plan G, which just the difference between Plan F and Plan G is that Plan G covers everything that Plan F does except for that Part B deductible. It's the only difference between the two is Plan G does not cover that Part B deductible. And so since new customers can't purchase a high deductible version of Plan F, that high deductible Plan G option is available for them if they decide to take that. And so we would just have that $2,370 deductible to pay before that 20% coverage kicked in. Because of that high deductible, obviously we're going to have lower premiums. And so we're not going to be paying nearly as much out of pocket every month in premiums, but that would just mean that we would have out of pockets for the services that we get through our medical care, whether it be inpatient or outpatient. So we may not be able to change plans. So if we're in that Plan G option, we may not be able to change plans without being subject to medical underwriting. And based on the company and certain states, there may be additional deductibles or fees based on what those companies are offering. Obviously, high deductible options may not be available in every state. So like we were hashing over earlier, Medigap plans K and L. These are going to be partial cost plans. They're going to be modified, so they're not going to pay all the 20%. Plan K is going to be 50% or equal to 10% of what's left off of Medicare. Plan L is going to be 75% of what's left or 15% of Medicare's 80%. And then we see our out-of-pocket limits, of course, with Plan K having $6,220 out-of-pocket limit for this year. And then Plan L's out-of-pocket limit being $3,110 for the year. So what this just means is that if we are on both of these plans, this is the maximum amount of money that we're allowed to be out of pocket as a patient for that given year. So in a given year, if we're out of pocket this amount of money as a patient, we will no longer pay any more out of pocket for the remaining calendar year. The plan will turn into 100% payer for those categories that it pays for. So Medicare Select plans are special types of Medigap supplemental policies that will put us into a provider network. Typically, these are not quite as popular as the standard Medigap policies. So these are different from your standard Medigap policies. Standard Medigap policies are going to cover you anywhere that Medicare works. So it doesn't matter which state we're in, what area we're in, as long as Medicare is accepted, our Medigap policy is going to be accepted as well. It pays anywhere that Medicare does. So that's the kicker. As long as Medicare pays, our supplemental pays as well. It doesn't go based off of networks. Now, these Medicare Select policies are different because they do put us into a network. To get full benefits, except in emergency situations, we will have to see specific hospitals and doctors that are within that plan's network. So it's going to be similar to Medicare Advantage plans in that regard, where for us to get the coverage out of that plan, we're going to have to see certain providers. They can be any of the standardized plans, so they can be any of the current plan types that are being offered under Medigap, and they generally will cost a little bit less than non-network plans, just because you do have to fit into those networks. Typically, you can switch to a plan with equal or lesser value if that plan doesn't seem to work out for you. Like I said earlier, typically you don't see select plans quite as popular as the standardized Medigap policies, mainly because most people want to stay flexible, and these Medigap policies will allow you to see anybody that's accepted, that's accepting Medicare. And so it's just going to keep you more flexible on who you can see and what you can do. But if you would like, or if you have clients that would like to look into Medigap Select policies that put you into those doctor networks, those are available. So with Medigap costs, your main costs are going to be your monthly premiums, and it depends on your age, where you live, company selling the plan, discounts, and medical underwriting. So we'll go through kind of all those individually. With age, typically we're going to get our best prices coming into Medicare at the 65 price. We can still purchase a supplemental policy if we're below the age of 65, but we're going to see a whole lot higher pricing, mainly because even though these companies may not be able to ask us medical questions, they see that we're under the age of 65 and they assume disability, which means they're going to assume medical history. So we're going to see costs higher than if we were coming into Medicare at 65. And of course, our price for a 65 policy is going to be lower than if we tried purchasing policy when we're 75, 85, 95, and so on and so forth. So the rate that we pay for our Medigap policy is going to be dependent on our age. Where you live, that's going to depend a lot as well, especially with select plans with doctor networks and things like that. Obviously, those are going to work out more in an urban area. And then, of course, with the standardized plans, it's going to be about locality when it comes to companies selling those policies. You're going to want to probably purchase policies that that particular company is licensed in your state to sell. With discounts, you will see some discounts when it comes to, of course, female policies. When it comes to Medigap, females are going to get a slightly lower price than the male counterpart when it comes to Medigap, mainly because they're looking at statistics there. when it comes to pricing. Typically right now, females are living longer than men. They have longer lifespans, and so you're going to see a female Medigap policy start out a little bit lower than the male counterpart. That's all statistic based. And then non-smokers. If you have a history of no tobacco use whatsoever, that's going to play into your advantage when it comes to certain plans that may offer you a lower rate based off of no tobacco use. And then you may see a little bit higher cost if you are a tobacco user. And then you'll also see something referred to as household discounts. What that just means is that's kind of designed for married couples. If you see something where, let's say, a company is giving us a 7% household discount, what that means is if both spouses, if husband and wife are on the exact same policy with that same particular company, then we will get that percentage of a discount. So it's kind of a household discount as an incentive for both parties to be with that company. And then we may be subject to medical underwriting. Like we said earlier, let's say that we purchase a policy outside of our guaranteed issue period, we would be subject to medical underwriting. So they're going to ask us a bunch of questions and to kind of hammer out to see what pre-existing conditions we have, what our medical history looks like, and from there they kind of determine what our costs are. They can kind of elevate those costs if it's a condition that they may be more uncomfortable covering, or they may just straight up deny us. So that can definitely play a part into our costs. And premiums are going to vary greatly for the same Medigap plan. You may have a particular company that's going to start us out at $96, and then you may have a particular company that's going to start us out at $120 for the exact same plan, even though the coverage doesn't change. So you're going to see a lot of variance when it comes to costs, even within the same coverages. So Medigap policies pricing based on age is non-age rated. Everyone pays the same regardless of age, 65 or older. Generally, it's least expensive over lifetime. So no age rated is going to be kind of least expensive as we go along. Issue age rated is just based on the age when we purchased. So obviously that's going to be cheaper if we purchase at 65 than if we purchased at 85. And this rate type doesn't go up automatically as we get older. And then this last one, the attained age rated, this is probably going to be the most popular that you see with the private plans on the market. Attained age is based on our current age when we come into the plan, and it does cost less when we're 65. And the way that these plans work is they kind of scale to our age as we go along. So the rate of our plan is going to go up a little bit every single year as we get older. So it's one of those that we can expect a rate change every single year. Premiums may go up due to inflation and other factors. So if plans decide to change for the market, whether it be inflation, whether it be market costs, etc., that's another time that these plans can go up. So when we're talking about an example to attained age rating plans, they can possibly go up twice during the year. They can go up when our attained age scales to our next year, and they can go up if the plan decides to make a change on the market. So it's possible that you could see up to 2 changes that year with your plan. So Medigap policies for people with disability or end-stage renal disease, typically it is a little bit harder for those with a disability or ESRD to get a Medigap policy versus someone coming in at 65. People with a disability or ESRD may not be able to purchase a policy until they're 65, mainly based off of the prices that they're going to start us out on the market, they're going to be a whole lot higher than if we were coming in at 65, and sometimes for people, they just may not be affordable. Some states will require insurers to sell Medigap policies to people with a disability or ESRD, so they may require to offer coverage for those with disability and ESRD, but their prices do not have to reflect the 65 price, so they're going to skyrocket those prices. Companies may voluntarily sell Medigap policies, so they may cost more than policies sold to people. So it's one of those that unless your state requires you to sell coverage, it's not guaranteed that that company may offer coverage at all for those under 65. So if it's not a required state, then they may or may not offer that coverage at their discretion. And they can use medical underwriting to determine whether or not they're going to accept those people into coverage. And then the next option is with disability, we may have some beneficiaries that are coming into Medicare and disability, but they may not be that far off from their 65th birthday. We can advise them on Medigap policy then, and we can advise them on what Medigap policy is going to look at when they do turn 65. So it won't be the only time that they're offered Medigap policy. So why would we switch Medigap policies? Some of the reasons that we might switch is if we are paying for benefits that we don't need. So if we got the top dog plan, the plan that's going to have the most coverage, and let's say that all we do is a couple doctor visits a year, maybe a couple of x-rays, maybe a couple tests, we're just not getting a whole lot done, then we may want to switch to a plan that's going to have a little bit lower coverage, but it's going to save us on premium. Because if we're not getting a lot done, then we're paying a lot in premium for services that we're not getting done. So we might have more cost-effective coverage if we drop down a couple of plan types and coverage and pay a lower premium for it. So that might be a reason that we switch, or if we need more benefits now. If we feel like we're going to have a bunch of medical expenses in the future and we want to go from a plan that is not covering a whole lot to a plan that covers absolutely everything that Medicare doesn't, then that might be another reason that we switch. If we want to change your insurance company, if we have a particular company that we've had some issues with, whether it be customer service, whether it be disagreements with their rate changes, whatever it may be, we may want to get a fresh start with another company. Or if we want to find a cheaper policy, if we feel like we can find a equivalent plan on the market later on by a company that's just going to give us a better deal, we may explore our options there. If we're not in our Medigap open enrollment period or our guaranteed issue period, we may pay more for the new policy because they will be able to put us through that medical underwriting and ask us about pre-existing conditions, so that could reflect our price sum, and it could reflect whether or not we're even accepted. So we want to make sure that before we switch to another policy, we want to make sure we're going to be accepted with that company first before we terminate our current plan, because that could put us in a world of hurt if we cancel a current plan thinking we're going to be able to go to another company no problem and end up getting denied. So we kind of want to make sure we go through that new company's medical underwriting process and get accepted before we make any changes there. Or, we could have a pre-existing condition that company decides to cover, but they put us through that 6-month look-back period with the pre-existing condition. So with switching Medigap policies, right under federal law, to switch only during your Medigap open enrollment or your guaranteed issue, right? If your state has more generous requirements, or if you move out of your Medigap select service area. So let's say that we had a select plan that was only covering us for doctors and providers in Middle Tennessee, and we moved to somewhere in Georgia that's out of that plan service area. We may have the ability under federal law to switch our Medigap policy without going through underwriting. With the 30-day free look back period, we can pay, or free look period, which basically that just means we have the ability to look at other Medigap policies to see if there is a company out there that's either going to give us a better deal or put us in a better situation. We kind of have a transition period of sorts, if you want to call it that. Anytime an insurance company will sell you one. So guaranteed issue rights to buy Medigap, it's a federal protection. So it's something that's been put into law as we have a federal protection for, is companies must sell you a Medigap policy. So if we're in our guaranteed issue right, no ifs, ands, or buts, that company has to offer you that coverage. They can't deny you in any reason if they sell that plan. All pre-existing conditions must be covered. They can't turn us away. And we can't be charged more, so they're going to give us one standard price. So when it comes to purchasing Medigap, that's what makes that open enrollment period for Medigap and that guaranteed issue period so important. It's because we can't get denied, and we're going to get one standard price. So it's obviously the best time to purchase Medigap policy. And then if we're coming off of employer health coverage, let's say that we're retiring and losing our employer health benefits, we must apply within 63 days of that coverage ending to qualify for that guaranteed issue right, as well if we decide to stay on employer coverage and delay Part B when we first come into Medicare. So examples of guaranteed issue rights is, let's say that John is in a Medicare Advantage plan. He'll have a Medigap guaranteed issue right if he joined when first eligible for Part A at 65, and then the first year wants to change to original Medicare. What this is called is a Medicare Advantage trial right. When we first come into Medicare, if we get on a Medicare Advantage plan, that first 12 months of us being on a Medicare Advantage plan, they call it a trial right. If any time within that 12 months, if we decide that we need to change back to original Medicare, we can do that anytime, and we'll have a guaranteed issue period to pick up a Medigap policy without being medically questioned or denied. If his plan leaves Medicare, so if the current plan that he is on just straight up pulls off of the Medicare market and has to drop their current beneficiaries, then John would have a guaranteed issue period to be able to switch. His plan stops giving care in his area. So same kind of thing. If they completely pull out of the area, pull out of the service area, or straight up leave Medicare, or if he moves out of the plan's service area. Another example of guaranteed issue rights, Mary is in original Medicare. She'll have a Medigap guaranteed issue right if her employer group health plan or union coverage that pays after Medicare pays is ending. So if it's a employer health coverage that pays or it counts as credible coverage and pays what Medicare does or better, then leaving that plan would grant us that guaranteed issue right. Or if we had a Medicare select plan policy before and we moved out of that particular select plan service area. So if we moved out of state or out of that plan service area, we would get a guaranteed issue right to switch to another plan. Guaranteed renewable policies. Medigap policies purchased after 1992 are guaranteed renewable, which is what that just means is that they're guaranteed to cover you that next year. So we know in 2022, this plan is still going to be active. your insurance company can't drop you unless one of these following happens. You stop paying your premium. So obviously, if you're not giving them the money that you agreed upon to give them to uphold the policy, they do have the ability to terminate you because you're not fulfilling your contract to hold that policy. You weren't truthful on your Medigap policy application. So if your eligibility to that plan is based off of falsified information, that company would also have the right to terminate you. And then the insurance company becomes bankrupt or insolvent. So let's say that the company that we're holding a Medigap policy with completely goes bankrupt and has to pull off the market and drop all their beneficiaries, then that would be a situation where we might lose our coverage. So we do have a right to suspend our Medigap policy for those who qualify for the state's Medicaid system. If we have both Medicare and Medicaid, we generally can't buy a Medigap policy because the reason being is most Medigap policies will act as the last payer, or Medicaid policies will act as the last payer. They're going to pay anything that is left. And so typically they're going to pay everything that is going to be left off of Medicare anyway, so there wouldn't be a need to carry a Medigap policy. So if we get enrolled in the state's Medicaid system and are able to get that Medicaid secondary, then we do have the ability, and we currently hold a Medigap policy with a company, we do have the ability to suspend it. Now, we would need to do this within 90 days of getting eligible for Medicaid, but the way that this works is we can suspend our Medigap policy for up to 2 years. We can freeze it. So basically what we're doing is we're freezing the policy. We're no longer paying the premiums on it, but we're still an enrolled member of that policy up to 2 years. So let's say that we get onto Medicaid and we decide to freeze our plan. We're no longer paying payments on it, but within that 2 years, let's say we lose our Medicaid benefits for whatever reason and we needed to go back to that Medigap policy. As long as we were within that 2 years, we'd be able to go back to it. No questions asked. The only difference in the premium will be however it adjusted based off of our attained age or the market changes with the company. Otherwise, the premiums and everything would go back to normal. So we can start it up again anytime within that new year, anytime within that 2 years of us freezing it, it can start up like normal. There will be no new medical underwritings or waiting periods, so they can't hold anything against us for coming back to it. Now, let's say that we waited longer than that 2 years, then that Medigap policy would automatically terminate itself. So let's say that if we decided to freeze our policy and we were on Medicaid for up until all the way until we deceased, then there wouldn't be a reason to renew that Medigap policy because we were being covered under Medicaid. So after that 2 years, the Medigap policy is going to auto terminate itself and we would just continue on with Medicaid like normal. So there is a reason to not suspend our Medigap policy if we chose to do that. One reason that we might do that is, let's say that even though we're accepted on Medicaid, or in Tennessee, it would be called TCAD, let's say that we were seeing a particular doctor who did not accept Medicaid or TCAD, and we needed coverage for that doctor, we would still be able to hold that Medigap policy to cover the 20% that Medicare did not for that doctor. So that might be one instance where we decide not to freeze our Medigap policy. And then, of course, if a beneficiary ever has questions pertaining to whether or not they should suspend their services, or just have any questions about coverage or how it all works with Medicaid, you can always call your state Medicaid office, or you can always call call us at SHIP. It's something that we're always going to be more than happy to help with, navigate all those questions. So the right to suspend Medigap policy with Medicaid, you can suspend it if your policy or your Medigap policy, if under 65, while enrolled or in your or spouse's employer health group plan. So even though we're disabled and under 65, if we're covered by our spouse's health group employer plan, then we can still suspend, Part B and a Medigap policy while we're covered under that plan. You can get your Medigap policy back at any time. You just must notify the insurer within 90 days of losing employer plan. So we would just want to do that within that 90 days. And there's going to be no waiting period for that. So this is a link to a premium comparison tool that we have designed by SHIP. It basically just runs through the different informations provided by the Tennessee Bureau of Commerce and Insurance. And basically what it is we just put in basic demographics, whether it be age, zip code, sex, and then what plan type we're wanting to compare. And then what it's going to do is going to generate a list of all the companies and the quotes that they're offering for those exact demographics. And it's going to auto-organize it from lowest quote to highest quote. So it's a neat little tool that we use to provide those comparisons for people, and that is the link to it. And I believe that is the end of my presentation here. So I will stop sharing and answer any questions that you guys have.
Tyler, somebody had asked, would a Medigap policy cover any late enrollment penalties if the recipient delayed enrolling in Part B?
Well, there are not going to be any late enrollment period or penalties for the Medigap policy itself. And so naturally, and because it's not a standard coverage that is designated in the chart of coverage for the Medigap policies, they would not cover any Medicare Part B penalties that you accrued. So you would, it does not pay on your Medicare Part B premium at all. So it's not going to cover any penalties that you accrue with Part B either.
Thanks, Tyler. And somebody had asked for more information on foreign travel emergency, and thank you to Mary Ann for sharing a link to someplace where somebody can go to get more information on that. Somebody had asked, Tyler, why would someone choose to purchase a plan A, K, or L? And somebody had offered that possibly because they were cheaper, or maybe that person was not looking for the same level of coverage that somebody who may be looking for something more would.
Yeah, that's exactly right. So someone who's purchasing a plan A obviously may not need a lot of coverage. They may only be going to the doctor a handful of times a year, and they were mainly just looking for a policy that was going to give them a safety net if they needed any extra services other than their routine care for that year. Versus, let's say, someone who purchased a plan G that covers everything except for the Part B deductible, has a very high amount of coverage, is going to cover everything that Medicare doesn't. People who hold that policy, either one, just wants the peace of mind of having 100% coverage, or two, has a lot of medical expenses that they need that 20% coverage for going forward. So the reason why someone would take one of those lower plans may be just because they didn't need that amount of coverage. So obviously they didn't want to pay the higher premium for coverage they didn't need.
Perfect. And it was pointed out in the chat too that most people are going to, when they are choosing a Medigap policy, that most of the selections within the state of Tennessee are going to be age attained rather than community rated or issue aged. You know, probably you're going to see a couple of issue age or community rated. For example, with Plan G, there's a community rated from AARP that's about $110. There's
Correct.
a Transamerica that's about $164, and then there's a community rated that is going to be probably over $300, it's $340 if I'm not mistaken. But most of them are going to start out attained age and be, you know, 95 to 98% of just age attained, with only about 2 or 3 at most of the issue age or community rated.
Yeah, you're exactly right. The attained age is dominating our market right now. Like Ryan said, 95% of the plans in the market are going by that attained age, and very few companies are either issue rated or that community rated. And just to point out, going back to the UMR POMCO Tennessee plan for state and teacher retirees, that plan is also community rated. So it does not go by the attained age of the private market. It is community rated, so everyone coming in on the plan starts out at the same rate.
Thanks, Tyler. And somebody had asked for that portal again, and that was shared in the chat as well.
Oh, awesome.
Too.
Thank you.
Yeah. And I don't see any more questions here, so I'll give it a couple more seconds and then pause the chat here. Pause the recording, excuse me.
Drug coverage with Part D for 2021 this year. And so prescription drug coverage is mainly covered under Part D, but it can also have some limited coverage based off of the situation for Parts A or Part B as well. But in general, the best rule of thumb to think about for whether you're getting prescription drug coverage under Medicare is whether it is medically necessary and deemed so by your prescriber. And it can also be based off of your healthcare setting. So like if you're in, a specialized nursing facility or in the hospital or something like that. It can also be based off of the medical indication, which is just why you need it. So for example, if you have cancer medications that you need to take. And then there's also sometimes any special drug coverage requirements, like for immunosuppressive drugs following an organ transplant or something like that. So first, we're going to talk a little bit about Part A prescription drug coverage. And generally, when you're looking at getting any kind of prescription drug coverage with Part A, which again is hospital, that's generally for any drugs that you have taken during a covered inpatient stay. So it could be whether you're in a hospital or an SNF. There are sometimes exceptions, like for chemotherapy drugs, if you're in an SNF, but also Part A will generally pay for drugs that are used in hospice care, but specifically just for symptom control and pain relief only. And then next, we're going to talk a little bit about Part B prescription drug coverage. So Part B will pay for some limited outpatient drugs. Again, most of the drug coverage that you're looking at with Medicare is going to be under Part D, but there are some outpatient drugs with Part B. So like anything that's injectable or infusible drugs given as a part of a doctor's service, drugs and biologicals that may be used for the treatment of ESRD or end-stage renal disease. It may be some drugs that are used at home with certain types of Part B covered durable medical equipment, like nebulizers or infusion pumps. and then also some oral drugs with special coverage requirements. It could be maybe some anti-cancer or antiemetic drugs, or sometimes specific immunosuppressive drugs under different circumstances. But when you're thinking about prescription drug coverage under Part B, the easiest thing to think about is whether it's something that you're going to the doctor for to get something like that. And then also there's certain immunizations that can be counted as being covered with this as well, such as flu shots, your hepatitis B shots, anything like that. But one thing that's an exception to preventative services of Part B covering those immunizations is the shingles shot. The shingles shot is actually covered under Part D, and I believe it's actually written on one of our future slides that we'll see in a moment, but that's something to keep in mind. For the most part, your flu shots and any other kind of vaccines are going to be covered under Part B, except for, again, the shingles shot. So this is going to bring us to the bulk of today's presentation about prescription drug coverage, which is Part D. We always tell people the easiest way to remember your Medicare alphabet with knowing which part is covering prescription drugs is just thinking D stands for drug coverage. So Part D, again, is covering drug coverage. Now, whenever you have original Medicare, you have the option to add on a Part D drug plan. And these are drug plans that have to be approved by Medicare. They are ran by private companies, and they are available to everyone with Medicare. And in most cases, you're going to have to actually elect to join the plan to get coverage. There are very limited circumstances where you may be automatically enrolled in a drug plan. For example, with Linet or anything like that, if you are deemed as very low income, you may automatically be enrolled in a standard drug plan. But for the most part, and especially for our volunteers, in most cases, whenever you are new to Medicare, you're going to have to find and compare possible drug plans and, again, choose to join that yourself. Now, when we're thinking about prescription drug coverage, there are actually two different ways that you can get this coverage for it to be counted as Part D. And there are the Medicare prescription drug plans, which is sort of what I've touched on a little bit already. These you have to add on with the original Medicare. So if you're going down the original Medicare path, a lot of times people may elect to get a drug plan and also get a Medigap plan as well. But you can also get drug coverage through a Medicare health plan with prescription drug coverage, which also is another fancy term for Medicare Advantage. There are quite a lot of Medicare Advantages out there, Medicare Advantage plans out there right now that also offer drug coverage. So overall, with the rest of this presentation, when I'm going to be talking about drugs that are covered, for the most part, the information will apply both to whether you have a drug plan or if you have a Medicare Advantage plan that also has drug coverage. But if there's any kind of distinctions, I'll note those as well. So first, we're going to be talking more about the PDPs, or Medicare Prescription Drug Plans. So these can offer some different combinations of coverage and cost sharing. All of these plans, again, to be approved by Medicare, have to offer a standard level of coverage that's set by Medicare. And these can vary in costs and also in drugs covered. So Medicare will have a list of a variety of medications that need to be covered, and the plans will need to be covering medicines that can treat a wide variety of conditions that Medicare beneficiaries may have. But when a plan covers a drug, they're not going to be covering the same exact amount for every single type of medicine, because every single type of medicine is not going to cost the same amount to manufacture and things like that. So because of that, every individual drug plan is going to have a tiering system where there will be different amounts that are covered depending on the cost of the drugs. And don't worry, we'll go over all of this a little bit later as we move on. But the big thing to keep in mind with this slide is that the drug plans are going to vary with the amount that's covered for each prescription that you take. And also another thing to note is that your benefits and your costs are, they have the ability to change every single calendar year. And so that's why it's always really important during the open enrollment period, which is October 15th through December 7th of every year, to review your drug plans so that you know if there's going to be any changes happening or if there is potentially even a lower cost option for you. So next we're going to be talking a little bit more in detail about the drug plan costs. And the costs are going to be varying based on the plan that you have. And here's just some general information that's listed about the types of costs that beneficiaries may have. There could be a monthly premium, which is going to vary based on your plan and also potentially based off of your income. And the monthly premium, though, is a standard amount that you pay to the plan each year. Now, it is possible whenever you sign up for a drug plan to get your monthly premium deducted automatically from your Social Security or your Railroad Retirement Board benefits each month, or again, you can just choose to pay your premium directly to the insurance company. So the first cost to think about, again, monthly premium. There also may be a yearly deductible if applicable. And then there's also going to be co-payments or co-insurance, which that is the amount that you pay whenever you go to the pharmacy to pick up your medicines. And a lot of times your co-payments or co-insurance costs will actually fluctuate throughout the year. And that's something that's really good to think about whenever you're comparing plans. So for example, you may choose to have a drug plan that has the exact same monthly premium every single month, but the copays that you pay at the pharmacy might change depending on the coverage phase that you're in. Or if you only go to pick up certain medications every 3 months, whereas other medications you pick up every single month. You may see a lot of fluctuation throughout the year in the amount that you pay in your copayment. So that's something really important to look at too when choosing a drug plan. And then there's also a percentage of cost while you're in the coverage gap, which is part of those coverage phases beginning at $4,130. And then there also can be very little after spending $6,550 out of pocket, which would put you into getting automatically catastrophic coverage. So as far as the different coverage phases go for each plan, one thing to think about too is that if you are new to Medicare or if you're comparing your plans to see what you want to enroll in, whatever the situation may be, is you'll want to look at what your medicine costs are going to be throughout the year and also what coverage phases you go through. Because if you are somebody who is only taking, a really generic low-cost drug like lisinopril, you may only stay in the first coverage phase, which would mean that you probably would pay the same amount for your lisinopril every single month. And in some cases, you may actually not have to pay anything at all, depending on how much the plan covers. But if you're someone who takes a lot of brand name medications as well as some generics, like if you take, what's an example? If you take Januvia or something like that, that's an expensive brand name medication, you may move through some different coverage phases. So you may move from having to meet your annual deductible, and in some cases, you may move from your costs before you pay the deductible into after you've paid your annual deductible. And in some cases, you may move also into the coverage gap. And then additionally, you may move out of the coverage gap into catastrophic coverage. But those coverage phases are going to be different for every single person. There's no kind of concrete set amount or anything for what coverage phases somebody's going to be going through. A good way to know what coverage phases you'll be going through is to look at the plan finder plan details whenever you're comparing your plans, because that will specify what coverage phases you're in. And next, we're going to talk a little bit more differently about your costs. And really focusing for a little bit on your monthly premium, because sometimes depending on your income, hey Lonnie, sometimes depending on your income, if it's above a certain limit, you may actually have to pay a bit of a higher premium. Now, to be fair, there is less than 5% of beneficiaries that do have to pay a higher premium. So it won't be very often that if you're, counseling somebody that you'll run into this situation, but it still is really good to know because there are some thresholds for the income for this, and that is what's called the IRMA, or Income Related Monthly Adjustment Amounts. And the same thresholds for Part D are also used for Part B. And by thresholds, I mean the same amount of income levels that you have to meet or be between. There's actually a chart that I'll show you in just a moment, but the income on this is based off of your IRS tax return from 2 years ago, just like with Part B. And with the IRMA, something to think about is if you do have to pay a higher premium, it is required to pay. And it will be an adjusted amount that's added onto your monthly premium every single month. And if you don't pay that adjusted amount in addition to the monthly premium, you potentially could be disenrolled. However, a lot of times what will happen if this does apply to you, or if this does apply to somebody that you're counseling, a lot of times that adjustment amount may be automatically deducted from Social Security in addition to the monthly premium if that's taken out. And you can also see here that the extra amount that is paid in this adjustment goes towards the Medicare Trust Fund. So it's not extra money that's going specifically to the insurance company. But now we're going to look a little bit at this chart here that is a better visual representation of what I'm talking about with IRMA. So this is based off of, again, 2 years ago for the tax returns. So let me make sure that everybody can see this here. On the left side, you can see in this first column that we're talking about income amounts for if you filed an individual tax return. And then we see if you filed a joint tax return. And then we also see if you filed married and separate tax return. But overall, what you would do is find what income level you were at and based off of how you filed your taxes. And then in the very right-hand column, you can see the monthly adjustment amount. Now, this is not accounting for however much your plan premium is. So actually, you'll notice here that YPP stands for your plan premium. So let's look at a couple of examples here. Let's say I filed an individual tax return and I made $64,000 that year there. So that is under $88,000. So here you can see that if I was in that situation, I would not have any kind of adjustment amount added onto my plan premium. So this would not be something that would apply to me. I would only have to worry about the plan premium that's listed in Medicare.gov's plan finder when looking at plans. But let's say that maybe I'm just very wealthy and I made $1 million in a year. So if I made $1 million and that was on my taxes and everything, then I would see over here that in addition to whatever my plan premium is for each month, I would also have to pay that plus $77.10. So this is a really great resource to use, this chart. If you are talking to somebody who is going to have that adjustment amount, then you can see exactly how much will be added on. So a great tip for if you are counseling a beneficiary and they are going to have an adjustment amount added onto their monthly premium is that as you're going through each plan option for them, make sure that when you say the monthly plan premium, that you also note, well, this plan premium is also going to be added to your adjustment amount. So if you talk to a beneficiary who is going to have the $12.30 adjustment amount added onto their plan premium, if you were talking to somebody who they wanted to go with a plan that is $20 each month for the premium, you would need to make sure to tell them to add on the $12.30. So it would actually, in reality, be $32.30 each month for a plan like that. And then next, we will also talk a little bit about coverage in the coverage gap. So here we have the years listed and what you paid for brand name drugs in the coverage gap, and then the percentage that you paid for generic drugs in the coverage gap. And you can see that it's a little bit different here with those percentages as well. But again, the coverage gap is not going to apply to every single beneficiary that you talk to. That's why it's really important whenever you're comparing plans to look at what coverage phases you will be going through. And actually, whenever I mail out, plan comparisons, sometimes I will always make sure to highlight what specific phase somebody is going to be going through, just because sometimes those charts can be a little bit confusing if you're not sure which coverage phases apply to you or not. So next, we're going to talk about another type of, another detail with Part D costs, and that is true out-of-pocket or TROOP costs. So these are expenses that count towards your out-of-pocket threshold of $6,550 in 2021. And after you meet that threshold, you get catastrophic coverage. And that means that you would again only pay a small copayment or coinsurance for covered drugs. And every single plan that is a Part D plan has to send out what's called an explanation of benefits, or an EOB, that would show your TROOP costs to date. So as far as what kinds of costs apply to true out-of-pocket or TROOP, one thing to note is that your monthly premium does not count towards that TROOP cost. So your annual deductible amount that you pay out of pocket, that will definitely count. Your co-payments that you pay out of pocket, those kind of costs will count, but your standard monthly premium that you pay each month is not going to count for that. So that's why it's always really good to remind beneficiaries to look at the explanation of benefits so that they can see, how far they are with that threshold. And another thing with this is that TROOP transfers if you switch plans during the year. So if you had, one plan and then let's say you had to switch for some reason, maybe you had a special enrollment period or something like that happen, then your TROOP total, those costs are going to be transferred. So you wouldn't have to start over in the middle of the year. But also another thing about this is that pharmacists do have to tell you if there is a better price available without going through your plan. And so an example of that would be if for some reason you are going to the pharmacy and it would be cheaper to pay for your medicines all out of pocket as opposed to getting coverage through your Part D plan, well, your pharmacist would have to tell you that. And that is good to know because then you know that your Part D plan is definitely saving you money off of that total retail cost of the drug. So next, we're going to move into Part D covered drugs. So these are prescription, brand name, and generic drugs. For a drug to be covered by Part D, it does have to be approved by the U.S. Food and Drug Administration, or the FDA. It does have to be used and sold in the U.S., and it also does have to be used for medically accepted indications. So this can include prescription drugs, biological products, and associated supplies, such as with insulin. Also, plans have to cover a range of drugs in each category, and also the coverage and rules are going to vary by each plan. And this is, again, another reason why there never would be any kind of one drug plan that's going to be the best overall, because every single Medicare beneficiary is going to have different drugs that they take, and they're also going to have different needs. You may be counseling somebody who is very loyal to a small town pharmacy, and you may be looking for a plan specifically that's covering that one pharmacy because it's very important to that person. You may be talking to somebody where the cost that's most important to them is just making sure that they have a really low monthly premium. You may be talking to somebody who prefers mail order and they want to make sure that the amount that they're paying for that mail order, that's their most important cost. So because of that, it's really good that the plans, that the coverage and rules are going to be varying because, again, every single person and every situation is going to be different. So next, we're going to talk a little bit more about required coverage, more specifically with Part D. So there are 6 different protected classes of drugs that have to be covered for a Part D plan. And these are cancer drugs, HIV/AIDS drugs, antidepressants, antipsychotics, anticonvulsants, and also immunosuppressants. And then this is also, again, here where it's listed that the shingle shot is also covered by Part D. So that's, again, another little exception there to the rule of that most vaccines are covered by Part B. The shingle shot and any kind of commercially available vaccines are going to be covered under Part D. So here is a list also of some drugs that are excluded by law under Part D. So we've gone over some protected classes that are required to be covered by Part D, but here are some that are actually excluded by law under Part D. And these would be any kind of drugs for anorexia, weight loss, or weight gain, anything for erectile dysfunction when used for the treatment of sexual or erectile dysfunction, anything that is related to fertility drugs, drugs for cosmetic or lifestyle purposes. An example of that would be any kind of hair vitamins or skin vitamins, something like that. Drugs for symptomatic relief of coughs and colds, any kind of prescription vitamin and mineral products, and also over-the-counter drugs. And this is a big one to think about too with over-the-counter drugs, because a lot of times if you're putting together a plan comparison for a beneficiary, they may include in their drug list if they take vitamin D supplements or something like that. But it's really important to make sure that they know that anything that's over the counter like that is not going to be covered under their drug plan. So next, we're going to go over some other ways that drug plans are going to be managing their access to drugs. And there is a handy little chart that's on this slide here for you. And the top row is talking about formularies. Now, I've already mentioned formularies a little bit, that they are the list of all drugs that are covered by a plan. And so again, this is the full list of that every single individual plan is going to have. With formularies, there's not going to be a one-size-fits-all formulary that's for every single drug plan. It'll actually be more individualized to the specific plan. So for example, if I have plan A that I'm looking at here, they may have a similar formulary to plan to, to this other plan option, but they're probably not going to have the same exact formulary. And then we also can see prior authorizations, and prior authorizations are another way that access to drugs is managed. And prior auths are not going to apply to every single medication, but with the drugs that they do apply to, all that means is that the plan has to be contacted by your prescriber before you're able to get coverage for that drug. So that just means if you have a drug that is in that your doctor would have to contact your plan just to make sure that they can approve coverage for that, and that they can approve the amount that you're being prescribed or the quantity that you're being prescribed for that medicine. There's also step therapy. Step therapy is another way that access to drugs is managed by plans. And an example of step therapy would be instead of going to a really expensive brand medication first, you may start out with a similar or less expensive drug. And if that drug doesn't work, then you may take a step up to the next type of drug. So, for example, you may try a really low-cost generic drug. And if that one doesn't work, you may try a similar one that is a lower-cost brand name. And then you would have to go through those before the final step of the most expensive brand name drug. And then another one is quantity limits. So with quantity limits, this is just how much the plan is willing to cover of the quantity of the drugs that you will be taking. So, and this can have to do with safety, like for pain medications or something like that, or cost. But if there is some kind of reason that it's medically necessary to have a higher quantity or a different dose that's above that limit, it is possible for your prescriber to contact the plan to ask for an exception. But again, it all has to do with whether it's considered medically necessary to have that high of a quantity. So next, I know I've already talked a little bit about formularies, but we're going to go more in depth about formularies, because not only does every individual insurance company have to have an overall list of what medications they cover, they also are going to have tiers, which is basically measuring how much they're going to be covering of that. And the tier system is going to be going numerically from 1, 2, 3, or 4, or specialty. So if we look here at tier 1, these would be the type of, most low-cost generic drugs. So if you have a tier 1 drug, you're probably going to be paying a much lower copayment at the pharmacy than you would if you had a tier 3 drug, or potentially a specialty tier drug that is unique and really high in cost. It's a really handy tool to know how your drugs are going to be tiered with each plan. And also, every single plan is not going to tier their drugs the same way. So if you are counseling someone and doing a plan comparison, make sure to look at the tiers, because you'll probably notice that if one plan tiers a drug as a tier 1 level, it's going to be much cheaper than if a different plan decided to tier it at a tier 2 level. You're going to see a difference in cost there for those medicines. And so next, we'll talk a little bit about formulary changes, which this is something that can happen every year with the plan. Now, something to keep in mind is that plans can only change their categories and classes at the beginning of each plan year. And by each plan year, we mean the calendar year. So if you are active on a plan for the year 2021 for this year, then that means that your plan would have started January 1st of this year, and it's going to be going all the way until December 31st. And sometimes plans can make some maintenance changes during the year, but they have to notify you, or they usually notify you 30 days before any kind of changes like that happen. And they may be able to provide you also a month's refill. And sometimes you can also ask for an exception if other drugs don't work. But something to think about and consider too when we're talking about formulary changes is that plans can immediately, without notice and at any time throughout the year, remove a brand name drug and replace them with a new generic drug if they meet certain requirements for that. Or they may remove drugs that are deemed unsafe by the FDA or withdrawn from the market by the manufacturer. But those are some very extreme cases like that. So if you're talking to a beneficiary and for some reason their medicine is no longer going to be covered, then it may be because of one of those situations. So here is some more information about how plans manage the unsafe use of specifically opioids. So a lot of plans now have what are called drug management programs, or DMPs. And that just means that if you get your opioids from multiple prescribers and pharmacies, your plan will probably be talking with your doctor to make sure that you need the medicines and that you're also using them safely. If the plan decides that your use of the drug isn't safe, they may limit your coverage, which means they may limit what doctors you go to. They may limit the quantity that you are able to have of the drug, and stuff like that. But you would get a letter in advance and also a second confirmation letter that includes the appeals process, because it is possible to appeal the decision if you believe that it's a mistake and if there's not any kind of misuse going on. There is also safety reviews at the pharmacy. So with safety reviews at the pharmacy, that would just be where an alert would trigger at the pharmacy for potentially unsafe amounts of the opioid use. And a lot of times when we're talking about mismanagement of opioids, it in a lot of cases will be dealing with benzodiazepines, which are typically prescribed for anxiety or insomnia and things like that, or if there's any kind of new opioid use. But also if your pharmacy for any reason cannot fill the prescription, then the pharmacist will issue a notice explaining that you can contact the plan to request a coverage determination as well. So next we're going to move on to Part D eligibility requirements. And so all this means is talking about how you can be eligible to get a Part D prescription drug plan. So you can only be eligible for Part D if you have Medicare Part A and or Part B to join one of those drug plans. You do have to have Part A and Part B to join a Medicare Advantage plan, though, with drug coverage. So while it is possible to join a drug plan if you only have Part A, it's not possible to join a Medicare Advantage plan with drug coverage unless you have both Part A and also Part B. And you also need to live in the plan's service area. And then here's some other eligibility requirements as well: that you cannot be incarcerated, you cannot be unlawfully present in the United States, and you also cannot be living outside of the United States. but you must elect to join the plan to get drug coverage. Again, in most cases, there's only very few cases, usually having to do with if you qualify for full extra help with your drug costs, that you may be automatically enrolled. But again, in most cases, you're really going to have to make sure that you are joining the plan, making the decision to enroll yourself. And that's also something that we help with a lot too, that we can actually put those enrollments through on Medicare.gov for beneficiaries. So next we'll talk a little bit about credible drug coverage, because what happens if you have an employer benefit plan or something like that that is giving you drug coverage and you are waiting to enroll in Part D. So some examples where you may have some other prescription drug coverage would be some kind of a group health plan, a retiree plan, if you have VA coverage, TRICARE, Indian Health Services, and also Federal Employee Health Benefits, or FEHB, for that program too. And when we're talking about credible drug coverage, it can only be considered credible if it pays on average as much as Medicare's standard drug coverage, which I believe this year is a little over $30. I can't remember the exact number off the top of my head, but that is there is a standard drug coverage amount, and if you have another plan, like from an employer, for example, if you hadn't retired yet, you would have to make sure that it is considered credible, that it is paying on average at least as much, if not more, than Medicare's standard drug coverage. But if you do have another plan like that, then your plan does have to inform you yearly about whether it is credible or not. And another thing that is important to note at the bottom of this slide is that if you have any kind of a lapse of 63 days or more in your credible coverage, you may have to pay a late enrollment penalty when you enroll in Part D. We'll talk a little bit more about the enrollment penalties and how specifically that's calculated. But as long as you're looking to avoid paying that penalty, it's really important to make sure that your current plan is considered as credible drug coverage. Sometimes you may have a plan that's considered credible for Part D, but it may not be credible for Part B, or it may be vice versa. So again, it's always really important to look at those notices that you get sent by your plan to know what is considered creditable and what is not considered creditable. So here we are also looking at your potential loss of your other coverage, because if you have a plan like with a retiree plan, for example, if you try to enroll in a Part D plan, you may actually lose your coverage with your retiree plan. But there's also some other examples that are included as well, like with some employer group health plans, or also if you are part of the program of all-inclusive care for the elderly, or the PACE program. And but also if you have any dependents on a plan like that with you, it may affect their coverage as well if you were to enroll in a drug plan. So the main idea to think about here is, if you're talking to a beneficiary who has another plan, like a retiree plan or something, and they're considering joining a Part D plan, you want to make sure that that is exactly what they are wanting to do, because you don't want to cause any kind of a loss in coverage if it's not possible to be keeping that. And so that's why at the bottom, it's again really important to check with your current plan before enrolling. Again, they always send out their lists about, or not their list, but their notices about whether it's considered credible or not. and they'll also let you know if you would be losing coverage by enrolling in Part D. So next we're going to talk a little bit about enrollment periods, starting with the initial enrollment period. And this is actually the same exact enrollment period as was previously discussed with Parts A and Part B. So that is something very handy to think about, that if you are talking to somebody new to Medicare, their initial enrollment period is applying to all of those things, to Part A, Part B, and also Part D. So here is a different way to also look at this time period as well, of those 7 months, which is just that if you were to join during the 3 months before you turn 65, then your coverage would begin when you're eligible for Medicare. So for example, if I'm turning 65 in May of this year and I decided to enroll in March in a drug plan, well, my drug plan would be going effective on May 1st, just like the rest of my Medicare benefits would. And now, if you do enroll during the month you turn 65, though, so again, if my birthday and I'm turning 65 in May, if I were to enroll in a drug plan, during the month of May, then I actually would be seeing my coverage for Part D starting the first day of the next month, so in June. And then, of course, if you were to enroll during the 3 months after you turn 65, it could be delayed 2 to 3 months, just depending on Part A if you have to buy it, or Part B as well. Now, there are also other enrollment periods too to consider. And generally, if you are going on the Plan Finder to do a comparison with someone and they might be part of a different enrollment period, what's really handy is whenever you are going to click enroll for a plan, you can actually see the list of other types of enrollment periods that could apply to somebody's situation. You can also find them listed as well on Medicare.gov. But here are, again, those other enrollment periods to consider. So if you have a drug plan, it's always a good idea from October 15th to December 7th of each year during open enrollment to reevaluate your plan and whether it's the best one for you. And again, because plans have the year as a calendar year for coverage, if you enroll in a new plan in November, let's say I really wanted to switch my drug plan around and I enrolled in a new one on November 30th. It's not going to be going into effect in December. It'll be going into effect January 1st of the next year. But there's also Medicare Advantage open enrollment period. And again, this is only for if you have Medicare Advantage already as of January 1st. So let's say you decided to enroll in a Medicare Advantage plan with drug coverage during open enrollment, but maybe you decided in February that you actually would prefer to go back to original Medicare. You'd have the opportunity to do that. Or you'd also have the opportunity to switch from one Medicare Advantage plan to another. But what you cannot do during January 1st to March 31st is switch around your standalone drug plans to a different drug plan. You also cannot go from original Medicare to Medicare Advantage during that time, unless you have, the exception to this is if you have extra help, which this is also going to be listed as well. I'll go over it a bit more in detail, but keep in mind that there is also a little bit of an exception to that rule if you have extra help. And also, when we're thinking about the general enrollment period that was brought up earlier, if you were to enroll in Part B during the general enrollment period, you can sign up for a drug plan from April 1st to June 30th, and your coverage would be starting July 1st along with your Part B coverage as well. So next we'll talk about a couple of a couple of special enrollment periods that may happen. Again, I would remind you that looking at the plan finders list is a really great way to just make sure when you're trying to enroll in a drug plan that you are in a special enrollment period. But here's a couple of different life events that may count as a special enrollment period. If you were to permanently move out of your plan service area, or if you were to lose other creditable prescription coverage, or if you weren't properly told that your other coverage wasn't creditable, or your other coverage was reduced and is no longer creditable, or if you enter, live at, or leave a long-term care facility, or if you belong to a state pharmaceutical assistance program or SPAP, or if you join or switch to a plan that has a 5-star rating, or if you qualify for extra help. So if you qualify for, and there's also other exceptional circumstances as well, not limited to this list, but talking a bit more in detail about if you qualify for extra help, if you do qualify, you actually can change one time during each of the other first 3 quarters of the year. So January to March, you may be able to switch your drug plan, as well as April to June or July to September. But it is limited to one time. So it is not possible to switch your plan in February and then again try to switch your plan in March, just like it wouldn't be possible to switch your plan in July and then switch it again in September. What's not listed here is, in addition to those 3 quarters, is the last quarter of the year, and that's because that's the the open enrollment period of October 15th to December 7th. So if you have extra help, you do have the ability, just like everyone else during open enrollment, to switch your plan, but you additionally have the first 3 quarters of the year to do so in each of those quarters once also. And so next we'll talk a little bit about extra help, dual and partial dual eligible special enrollment period limitations, because there are some limitations depending on what kind of a special enrollment period you have. So as of January 1st, 2019, this is again talking about how you can only change plans one time per calendar quarter, as I previously mentioned on the last slide. But there is also another 3-month special enrollment period following one of 2 different situations. So if you have a gain, loss, or change in Medicaid or extra help status, then you'll have 3 months after this event occurs to have the special enrollment period. But also, number 2, if you have a notification of a CMS or other state-initiated enrollment action, you also have that 3-month special enrollment period after that as well. Another thing about limitations with SEPs is if you are an extra help, dual, or partial dual eligible who's determined to be potentially at risk or at risk for misuse of frequently abused drugs, you will not be able to use this special enrollment period to change plans. You'll still be able to use the open enrollment period from October 15th to December 7th. But if you are, one of those determinations, so potentially at risk or at risk for the misuse, you would not be able to use the first 3 quarters of the calendar year to be able to change plans once during each of those quarters. And then continuing a little bit more about these limitations, there was also the Comprehensive Addiction and Recovery Act that established the drug management programs. These are what I touched on a little bit earlier in that chart that was talking about the ways that plans are managing opioid abuse and other types of prescription drug abuse. but you will be notified if you're somebody that is determined to be potentially at risk or at risk. You will be notified of such. And this limitation of not being able to use those first 3 quarters of the calendar year, the limitation is going to last until the at-risk determination expires or until it's terminated by the plan. But also it is possible to appeal your at-risk status to the plan, but the decision overall is based on the opioid use, dosage, and number of providers used. But again, if you fall under having one of those limitations, or if you have somebody that you're counseling that falls under having one of those limitations, again, you still can use the open enrollment period and some of the other general special enrollment periods that were listed previously. So now we're going to talk a little bit more in depth about that Part D late enrollment penalty, because there is some calculation that we would need to do to figure that out. So just like how if you were to enroll in Part B late, you would have a penalty. If you were to enroll in Part D late, you'll also have an enrollment penalty. The only way to not have a Part D late enrollment penalty is if either one, you had some type of creditable drug coverage, like an employer plan if you retired after 65, or if you qualify for extra help, you would not have that late enrollment penalty. But the way that the penalty is calculated is that it's actually just 1% for each full month eligible and without creditable prescription drug coverage, multiplied by the base beneficiary premium. And this year, the standard base premium is $33.06. So we would be multiplying 1% times $33.06, which rounds out to about 30 cents for each month that you don't have coverage. So to give a scenario where we would have a late enrollment penalty, for example, let's say that I was eligible for, starting my Medicare and everything in January 1st of this year. But let's say that I don't have any prescriptions. So I decided, well, I'll wait to enroll in Part D until I have prescriptions. A couple of years go by, maybe 2 full years go by before I finally decide, okay, it's time for me to enroll in a drug plan. If I didn't have any kind of credible drug coverage and I don't qualify for extra help for those 24 months, then what we'll have to do is multiply that 30 cents by 24, because that would be the number of months that I went without coverage. And whatever that amount is going to be added onto every single monthly premium for as long as I have drug coverage. So if I went without for 24 months, that's a little over $7. So, if I am looking at a plan that has a monthly premium of about $20, it's actually going to be a little over $27 for that plan. So that is another important thing to consider. If you're talking to a beneficiary who is going to have that late enrollment penalty, make sure to add that enrollment penalty on to their monthly premium, just so that they're aware of the actual amount that they will be paying each month. But it's important to note that the amount for that penalty is going to change every year. So this year and that's because of the base premium. So this year it's $33.06, but next year it's not going to be the exact same base premium. So make sure that when you are trying to calculate everything, that you know the exact base premium for what year it is, and that you're going ahead and multiplying that 0.01 or for it to count as that 1% to figure out how much for each month is going to be added on. And so next we'll talk about some things to consider before you join a drug plan. And there's a list of some important questions to ask. And these could be things that you're asking yourself if you are looking at drug plans or reviewing, but also for any of our volunteers here, if you are counseling somebody, it's also good to ask these questions of them as well, especially if it's somebody who's new to Medicare, or if they've never had a drug plan before. It's also good to ask these questions. And these questions are, one, do you have any other current health insurance? Again, just because earlier when we were talking about how things like retiree plans and employer health benefits, or if you have the VA benefits, anything like that, they can interact differently with Part D. That's an important question to ask. And then we have number 2 is any prescription drug coverage you might have as good as or credible Medicare drug coverage. So if you do have another plan like that, you want to know if it's credible. And then 3, how does your current coverage work with Medicare? And then 4, could joining a plan affect your current coverage or a family member's coverage? Especially, again, if you have any kind of plan that would cause you to lose it if you join Part D, it's important to know that information before you go any further. And then next, we'll talk a little bit more about what new members can expect. And this is really great information to know, because a lot of times after you enroll somebody in a plan, it's good for them to know what's going to be happening after that. So the plan that you join is going to be sending you an enrollment letter, any kind of membership materials, including an identification card, and that is the card that they'll be taking with them to the pharmacy whenever they pick up medicines. And then also some customer service contact information. That is good to know that as well, because sometimes people may not get their card in time, or maybe they don't have the right address listed on file. This has definitely happened where people that I have called in to talk to me, they've not received their card yet, or maybe they've not received their enrollment letter. So it's really good to make sure that they know that they're supposed to expect that, because that ID card is very important for when you pick up your medicines. But something to note is that if you don't get your ID card in the mail, it is possible to print off for Medicare.gov a temporary drug card that you can take with you to the pharmacy. So, for example, if I am, going to have my drug plan starting May 1st, and I enrolled today in a plan at, kind of the last week of April, even though my plan's going to be effective May 1st, it may be possible that my drug card doesn't come in the mail in time before then. So if situations like that arise, it's great that you can print off the temporary drug card to take with you to the pharmacy. So that's an important resource to know about as well. Now, if your current drug isn't covered by the plan that you have, you can get a transition supply that generally lasts 30 days. You could also work with your prescriber to find a drug that is covered, but you can also request an exception if no acceptable alternative drug is on the list. And another one that I'm going to add to that is if you have a drug that's not being covered well by your plan, make sure to review your plan during open enrollment to see if there's another plan that is going to be covering that drug much better. Sometimes people will call in and they didn't even realize that they had other options to look at, or they may not even realize that during the open enrollment period, they can switch, that they can switch that plan, and that there may be one that has better coverage for them. And so that's going to bring us to the annual notice of change, which is what all Medicare drug plans have to send to their members no later than September 30th of every year. And then there's also evidence of coverage to be delivered by October 15th. But the annual notice of change is going to be including information for the upcoming year. So things like your summary of the benefits that you get, the formulary of what drugs are going to be covered with your plan, and if there's any changes to your monthly premium or cost sharing. Also, some plans may include a pharmacy directory of what pharmacies are considered preferred in network. That kind of information is what's going to be sent with the annual notice of change. It's really important to look at it carefully And again, to see if you need to look at your drug plan and whether you should change during open enrollment. That's why it's really good that the annual notice of change is supposed to come out no later than September 30th, because it gives beneficiaries enough time to look at that a little bit before open enrollment starts, and then they have plenty of time to look at their options as well. And that's just going to bring us all the way to the very end. There's an appendix here that has kind of just at a glance information about the enrollment periods, and it takes up the last two slides here. This is a really great resource to print out at a glance to look at if you have somebody that, you know, you're not sure exactly what date they can apply to change their drug plan or anything like that. But other than that, that is going to be everything that I have for you all with this presentation. And I did notice that as I was talking, there were some questions that were coming in. So I would love to answer any of those. Let me stop sharing here. Okay. All right, so what questions do people have about Part D?
Amanda, I'm just gonna share my screen of the agenda, if that's okay, while we're doing this, just so when we share on YouTube, it's of something in the background here, not just all of our faces in chat.
Okay.
There were some questions in here. Somebody had asked why so many drugs are so expensive, and that it seems like no plan wants to cover particularly high-cost medications, which it was pointed out about screening people for extra help assistance, and also for those drug manufacturer assistance programs like Needy Meds or RX Assist that are available out there. Somebody wanted you to repeat the shingle shot information, if possible.
Yes. So first, really quickly about Needy Meds, I absolutely agree. Needy Meds is a great resource. I use it all the time because there was one situation that happened. I can't remember the name of the drug, but this client I was talking to had some newer brand medicine that for some reason was not being covered by any of the Part D plans. So we went and looked on Needy Meds for some options for her, and also she ended up actually being able to go back to her doctor and find a better option to take that would be covered, because that one was really expensive. But Needy Meds is great, and when you go on that website, all you have to do is type in the name of the drug and that you're looking for assistance for, and any possible manufacturer programs that are out there are going to pop up. And you can, sometimes they'll have links to the websites, sometimes they'll just have some general information about it and a phone number. Sometimes they'll have certain eligibility requirements, but it's overall a really great resource to give people for that. But as far as the shingle shot goes, so most vaccines are going to be covered by Part B, which again is medical. However, commercially available vaccines, such as the shingle shot, are actually going to be billed and covered through Part D for drug coverage. So that's just the general thing to know about that. Was there any specific question about the shingle shot?
No, it just said repeat the shingle shot information at some point there. Okay. Somebody had asked as well if you know where any of the IRMA money goes.
Yes, it goes to I think it's called the Medicare Trust Fund, which, you know, goes for all sorts of different things about maintaining the Medicare program just in general. And those trust funds are I believe, I can't remember the specific names of them, but I know that there are two different trust funds that fund the Medicare program. So if you have somebody that is having to pay that adjustment on top of their monthly premium, that amount is going to be going to one of those trust funds to keep the Medicare program going. It's not going to be going to the specific insurance company that they're getting coverage with.
Amanda, you're exactly correct. There are two, the Hospital Insurance Trust Fund, or the HI Trust Fund, and then the Supplementary Medical Insurance Trust Fund, SMI. Obviously, for the Hospital Insurance Trust Fund, sources like your income taxes, paid on Social Security benefits, interest earned on trust fund investments, Medicare Part A premiums for people who aren't eligible for premium-free Part A, those go into that fund. And then for the SMI, the Supplementary Medical Insurance, those are for your Part B and D benefits. Those are going to be from premiums for people enrolled in Part B and Part D that are going to go to fund those. So you're exactly right on that.
And I also see.
Go ahead. I'm sorry, Amanda.
Oh, I was just saying, I also see another question that if a person pays more for a Part B premium, they will likely pay an additional on Part D, correct? Yes, most likely. Again, the IRMA is the same. It's based off of the same income limits and thresholds as for Part B. So it's a good idea to check just in case, but you know, they're likely going to have to pay the additional for both of those parts.
And then the question had come in, are there some plans that don't cover cancer medications?
Mm-hmm.
Which had
yes, but any kind of information like that is usually listed with plan details. So whenever I'm comparing plans for somebody, that's why it's a good idea, since there's just so many different drugs and they're all covered at different amounts, to have it tailored to the person that you're comparing for. So if you have somebody that is taking a medicine like that, you'll want to make sure to include it in the comparison to see if it's getting covered or not. Sometimes on plan details, it will list that certain outpatient cancer drugs are not covered, and that's because they may be covered actually under Part B medical. So that's something to keep in mind, that your drug plan may not be covering it because a different part of Medicare actually is covering it.
and there were some questions about Medigaps and PDPs that some people had questioned. Do Medigaps have PDPs connected to them?
Not currently. There were some Medigap plans that were sold before, I think, 2006 that may have included some drug coverage. And if you have one of those Medigap plans, like if you've had the same Medigap plan since 2004 that included drug coverage, then you can keep that drug coverage. But if you were to decide that you no longer wanted your Medigap plan anymore, or if you wanted to decide to enroll in Part D, you're most likely going to have to pay a late enrollment period. But currently, there's not any Medigap plans that would be offering it. Sometimes the same insurance company will sell a variety of different types of Medicare plans. So there may be a company where they have a Medicare Advantage plan, and they also have Medigap plans, and they also have maybe 2 or 3 different drug plans as well. But it's not going to be, you know, I would say it's still a good idea to compare costs just in a non-biased way, because you may have one company that for your particular needs is really great for your supplement, but that doesn't mean that it's going to have the best coverage for your drugs. So it's still a good idea to compare.
Is the COVID vaccine covered under Part B or Part D?
I believe that the COVID vaccine, correct me if I'm wrong, Ryan, but I believe it's covered under Part B.
It is.
Yeah, and so
Yes.
it's not, yeah, Medicare beneficiaries should not be having to pay anything for the COVID vaccine. So, yeah.
I think when people go to a retail pharmacy, though, they'll have to bring their red, white, and blue card so they can bill the insurance, or bill Medicare. But other than that, no
Yes.
cost.
And
Mm-hmm.
and that, yeah, that'll be just more for administrative costs if you're
Mhm.
receiving it, like Alanka said, at one of your commercial pharmacies.
Alrighty.
And
Do we
that
have any more
that was all the
questions?
questions.
Good job.
Let me go ahead and pause the recording.